Good morning, everyone. Mayam, aigi screen se ubibra. Am I audible? Am I visible?
Yes, Cecil.
Okay, thank you. Okay, Mamangi, the day before yesterday, we had started our virtual orientation on NQAS. We have completed area of concern A, service provision, then patient's rights, inputs, and then support services. Okay. So just to have a brief recap, service provision is about all the availability of the services that is supposed to be provided by the district hospital or sub-center or PHC. Service provide tawgadoba mayamdo, that is all included in the service provision, where they do not ask about any details. They just ask whether that particular service is being provided in that center or not. Patients' rights is about barrier-free, financial freedom, free of cost services, gender-friendly services, disabled-friendly services, all those things, entitlements being given, IC materials displayed, all those things comes under patient rights. Inputs is all about your infrastructure, human resources, staff training, competency of staffs, drugs and diagnostics, patient amenities, furnitures, whatever materialistic things which is required to run a facility, that includes in the inputs. And support services is about non-clinical management of the hospital. Non-clinical management of the hospital, like your laundry, your kitchen, dietary services, management of drugs, stocks, management of stocks of the consumables, management of your RKS funds, and all those committees and non-clinical committees, all those comes under area of concern D, that is support services. Now let's begin with the area of concern E. Today we will be having area of concern E, that is the clinical services, also called as clinical and wellness services in case of armed sub-centers, because for armed sub-centers, wellness is also a very huge part, which includes yoga, ayush, eat right, all those things comes under wellness. So for armed sub-centers, it is also called as wellness, clinical and wellness services, whereas for others facilities like district hospitals, PHC, CHCs, we call it clinical services. We will be also covering today the infection control part, which is area of concern F, and then we will be dealing something about the area of concern G, that is quality management, and H, that is outcome indicators, which is the calculation of all the like a report card calculation of all our achievements, that is in outcome indicator. So let's begin with the area of concern E, that is clinical services. Clinical services, we divide it into three parts. One is the general clinical processes, one is the specific clinical processes, and the last one is RMNCHA along with the national health programs. So first is the general clinical processes, which is part A. Part B is specific clinical processes, and part C is RMNCHA and other national health programs. RMNCHA is still one of the most important component of NQAS and all the health facilities. So we have a different different part in clinical services. So general clinical processes deals with from the registration till the discharge of the patient. Part B deals with the specific clinical processes like ICU, hemodialysis, OT, all those things comes under specific clinical processes. If we see, there are in a district hospital, there are 24 standards in clinical services. In CHC, there are 22 standards. There are 15 standards in PHC, and there are 9 standards in UPHC. For armed sub-centers, we have only 18 standards. So please remember, whenever we talk about clinical services, we divide clinical services into 3 parts. One is the general clinical processes, second one is the specific clinical processes, and the third one is the RMNCHA. So this is kind of a brief idea about your general clinical services, specific or special clinical services, and RMNCHA. In the general clinical services, it will start with the registration and it will ends with discharge. In this process, there will be lots of history taking, how to maintain a prescription, how to clinically assess a patient, if there is any like how to take vitals, all those things, two-way referral system, nursing care, continuity of care, safe drug administration, all those things will come under general clinical care. In the special or specific clinical care, it deals about the ICU, emergency services, disaster management, the diagnostic services, blood bank and storage, anesthetic services, surgical services, and end of life care, and death, that is in case of mortuary. And the third part is RMNCHA, as we have discussed. RMNCHA, it starts with antenatal care, intranatal care, and postnatal care. This is about the maternal, the newborn, infant, and child health, abortion and family planning services, and adolescent and sexual health services. This comes under RMNCHA. Along with RMNCHA, in case of PHCs, UPHCs, and sub-centers, we will be dealing with national health programs like TB, AIDS, leprosy, vector-borne, all those things will come under on the third part of this, third part of clinical services. So general clinical care, specific clinical care, and RMNCHA. So first, let's discuss about general clinical services. General clinical services, it starts with registration and it ends with discharge. So first thing is E1, as we saw before. It starts with the general clinical services. It has 9 standards. That is, E1 is registration, consultation, and admission. E2 is about assessment and reassessment of the patient. E3 about continuity of care, or we can also call it referrals. Then E4 is all about nursing care, documentation in the nursing care. E5 is about high risk and vulnerable patients. E6 about generic drugs. E7 is about safe drug administration. E8 is about clinical records, and E9 about discharge. We will go through this one by one in details, but please remember, in case of clinical services, on the first part of clinical services, that is general clinical services or general clinical processes, it starts with registration and ends with discharge. So in the level of district hospital, let's see, in the level of district hospital, E1 deals with the registration, consultation, and admission. E2 is about clinical assessments. E3 is about continuity of care and referrals. Referrals should be upward referral and downward referrals both. Then comes E4, that is the nursing care. E5 is about high risk and vulnerable patients. E6 is about standard treatment guidelines. To follow standard treatment guidelines wherever we write a prescription or whenever we deal with a disease, to follow the standard treatment guidelines, that comes in E6. Then comes the generic drugs and rational use of drugs. To avoid polypharmacy, to avoid antibiotics wherever we can, all those things comes under this E6 or clinical services. E7 is about safe drug administration, which is followed by nurses and healthcare providers in the facility. And E8 is about maintaining, updating of the clinical records and their storage. And E9 in the last, it is about discharge of the patients, the discharge policy, discharge procedure, all those things comes under discharge of the patients. Now let's see about PHC. It is also the same thing, but it starts with registration, consultation, and admission. It doesn't have a specific standard for clinical assessment and reassessment of the patient, but it is kind of included in E1. Then we have this continuity of care or referral of the patient in E2. Nursing care is in E3, safe drug administration and standard treatment guidelines in E4, clinical records in storage is in E5, E6 is about discharge of the patients, and till here the general clinical processes are done. But above that, we include the emergency services, disaster management, diagnostic services, these are all actually part of specific clinical services, which is being implemented on E7, E8, and E9 for primary health centers. Let's see about ARM sub-centers. ARM sub-centers also for general clinical processes. It starts with registration, consultation, and clinical assessment, reassessment. It starts with E1. Then comes continuity of care. As we can see, continuity of care is there in every level of facilities. Then it is here, it ends for ARM sub-centers. General clinical processes ends here, and E3 starts with the diagnostic services. E4 is about safe drug administration. E5 for standard treatment guidelines. E6 about nursing care. E7 about emergency, and E8, E9, all those comes for those extra expanded 5 package of services in ARM sub-centers. Now let's go into details. First, let's see what is E1, which deals with registration, consultation, and admission of the patient. Registration, consultation, and admission of the patient. It is about registration. We all know systematic calling, seat arrangement to have their own unique ID number, OPD consultation, ticket thava, patient ki history lova, details lova, and cutting of OPD tickets like that. Let's talk about this UID. UID is always about your ABHA ID. If ABHA ID is not available, a facility should implement a technique or a mechanism to give unique ID number to a patient, which will never be repeated. If a patient call if a patient call X, 42 years of age, from a village Y, he should be given one unique ID number, which will never be repeated and which will never be taken by another one. So one suggestion or one idea is to have it like 2025 March 001, like that. So this is the kind of unique ID number that will never be repeated. So this means that it's year 2025 March 1st, March, and this is the first patient, and then it'll go like 03002, like that. This will continue and it will just continue like that. And when it comes to April, it will be like 02025 04001, like that. This, if you follow this kind of mechanism for giving a unique ID number to a patient, then that ID number will never be repeated. If this patient X have been allotted this unique ID number, whenever he comes for follow-up, whenever he comes for any follow-up or repeated visits, then this can be used as his unique ID number whenever we cut the ticket for this patient. So unique ID number is very much important for all patients to be given if ABHA ID is available. If ABHA ID is available, then it's very good. We can go through ABHA ID in the e-hospital also, it is recognized. But then if e-hospital is not implemented, if ABHA ID is not there for a patient, then we should implement, or we should have a mechanism to generate a unique ID number for a patient, which will never be repeated, which cannot be taken by another patient. So that deals with the OPD consultation UID, that is E1 and E2, which deals with registration, consultation, and admission. E1.3 is about admission. This is for district hospital, SDH, and CHC only. This process will be implemented in all level of facilities like primary health centers, like CHCs, like district hospitals. But for the level of district hospital, SDH and CHC, there should be a mechanism to add extra beds, to have extra beds in case of emergencies. That is included in E1.3. There should be a special criteria or special focus on MLC cases, prisoners, emergency cases, SNCU, ICU, pediatric ward, NRC, PPU. But these are all, you don't need to do anything, but this has to be implemented in your SOP while framing your SOPs. Like in your SOP, there should be one point, one standard that states about addition of extra beds in case of emergency or in case of disaster. There should be a standard operating procedure, especially mentioning cases for MLC, prisoners, emergency cases, SNCU, etc., etc. Now, this thing, both of this are specially for district hospital, district hospital, SDH and CHC specially. All the first 4 points are for all level of facilities like primary health centers, sub-centers, everywhere. Specific for sub-centers, we have this empanelment and registration of individuals and families, follow-up and reassessment. This is a separate standard which we will be seeing in subsequent checklist. So this is the just a small example. This is the OPD checklist for a district hospital. In the OPD, first point is about unique ID number, which is given to the patient during registration. And as we can see here, it is record reviews. From your prescription or from the OPD registration register, they will see whether every patient has been given a unique ID number. It just cannot be 001, 002 because that will be repeated. Once the financial year passes, that particular number will be repeated. So please make sure a unique ID number is always given, so that that unique ID number cannot be repeated in future, and it will be specially for that particular patient. So this is RR, which they will see from the OPD register or from the registration counter register. Patient demographic details are recorded in OPD registration, like check the names of the patient, age, sex, address, etc. If, I just want to add one point, if the age is less than 5 years, please write 4 years and 3 months, like that. Months should be included. If it is more than 5 years, then you can just write 5 years, 6 years, 7 years, like that. But if it is less than 5 years, always make sure the month is also written in case of children less than 5 years of age. The third one is directed to relevant cleaning by registration clerk based on complaint. They will have to first screen the patients where they have to go. In emergency wards, it is like a triage. First triage will be done, and if it's an emergency, then they will skip the line. They will skip the OPD or emergency line. Registration clerk is aware of categories of the patient exempted from user charges. For example, for pregnant women, we do not usually charge the user charges like ticket fee or anything like that. So all those things are while we interview the staff, who all patients will be exempted from the user charges, that will be known by the staffs. The second is about procedure for OPD consultation. This is about registration of the patient. This is about OPD consultation. There is a procedure for systematic calling of patients one by one. In the district hospital level, if we have some financial some financial support, or if we have some funds for procuring the ticketing system, then that's very good. The one which the medical officer who is sitting inside mana next haiba matamda next the token system taurakanda serial number 1 serial number 2 na mana thoglakpado, that is a very good practice. Akoina kaigumba fund laitaragadi district hospital gi level dadi that can be implemented. PHC CHC gi level da kitang waba yai, but then ticketing system da koi token system da la kanda magi kauraga chatkibado ado itaragadi that is a very good practice. patient ki history lobra logdabra yengdoni from the record reviews, from the OPD records, or from the prescription paper. Physical examination is done and recorded wherever required. Details of the physical examination yaubra, provisional diagnosis yaubra, investigation ibra. It is very important that we write the provisional diagnosis. Even if the assessor is not a doctor, even if he comes from an NGO or something, he will definitely see right or wrong, whether in a prescription or in the OPD register, diagnosis is written or not. So provisional diagnosis, Amadi, it is a very good practice to include provisional diagnosis in our prescription sheet as well as the OPD register, because when assessment or the diagnosis may be correct, may not be correct. That is another thing. But then Irambra, Iramdabra, the assessor will check. Provisional diagnosis record is another checkpoint. Sigi provisional diagnosis ama Iramba, say it doesn't cost money. To have a boundary wall, it also cost 2 marks, and to write provisional diagnosis, that also cost 2 marks. So next, let's see about IPD. Small thing about IPD, there is no delay in the admission of the patient. Admission is staff interview or observation. The yengani or kaigumba kona time motion study. If we do time motion study in the prescription, then we will know that there is no delay in the admission of the patient. I will talk about time motion study in case of quality management. Admission is done by a written order of a qualified doctor. Admit the patient on a prescription the iramba. Adugi potuni ko mana haise. Time of admission is always recorded in the patient ki record ta. Karankanda IP ki notes the Karankanda admit tarambano habado adu mayam the yaudone. So these are very clinical and technical port naktaniko. This doesn't need that much of funds, and this is very scoring. Area of concern clinical services say yam chawe. It is very big. It is one of the biggest area of concern in NQAS, and most of them it's all about our processes ki part to neba iramba documentation tauramba adugumba part to neba, and it doesn't cost money, and most of the times usually facility the mark the yamna phangba so clinical services is the oeba. There is provision for extra beds. This is about district hospital ki IPD da in case I gi ward amada bed kun thare na khalasi, in certain ward amada 20 thare dengue gi outbreak amatore natraga poisoning amatore. If we have about 30-40 patients, then we should have the provision of extra beds. Subcenter ki level da, let's see just a small example of subcenter ki checklist. Da E1.1 is about procedure for empanelment and registration of individual and families. Subcenter they deal not only with the patient but always with the family. Aduna moi family folder yengba screening tauba community based assessment checklist tauba, they see the community as a whole. So Arm Subcenter is aware of the constitution of its catering population. Demographic composition je kamaina hot kadage habado I will I kona kenoma yenghange. For the subcenter level, for CHOs, I'll just give you an Excel sheet on which you can just put up the details of the current population and all NCD population, all eligible couple, all sick newborns, everything will be, the estimations of all those will be calculated automatically. Established procedure for demographic composition, number of individuals of different age groups. Different age groups like NCD population, 30 plus population, though 37% of the population elderly population na kayano, 65 years and above na kayano, all those things needs to be there written, and it should be pasted on your wall. Arm Subcenter periodically estimates number of beneficiaries for RMNCHA services. RMNCHA services tadi ay nga sa haiba dumaina eligible couple ke ano, live births ke ano, sick newborn ke ano, pregnancy with complications ki percentage ke ano, adugumba mayam do loin lakado ni ko. But these are just documents ngakane noina atopa extra work amata go nate. It is just the documents nogi asha dagi head count hangasu ya, or you can just estimate according to the government of India guidelines like 15% should be nangi kano oidoni 15 out of the live births, 10% of the live births are sick newborns kind of minor ko adugi mayam do hot padugi wani. Population above 30 years, men and women, just adding for CHO 30 plus years ki population se 37% of population do oidoini. Out of this 37%, 49% should be females and 51% should be males. Aduna NCD population da 37% of your total population is your 30 plus population. 37% to gi manung da 49% will be females and 51% will be males. Nang na cancer screening torapa matam da, when you screen for cancer, when you screen for oral cancer, you will screen for all the 37% of the population, while you screen for breast and cervical cancer ki screening tauba matamda, you will screen for only 49% of that 37%. 37% to gi manungda 49% nupi oirido nupi du khaktang nangna cancer gi screening tawne habani ko. Subcenter gi level da we will come back again later. So next, coming to the E2. E2 is about clinical assessment and reassessment. Clinical assessment, the initial assessment, documentation of initial assessment, history taking, provisional diagnosis, all those things. Moida akoina say yaubra hangambay wani ko. Akoina iba matamda, do we document the assessment, the history, the provisional diagnosis? Do we write it in our prescription sheet? Do we write it in the OPD register? Follow up and reassessment of the patient's key mechanism, treatment plan, care plan as per needs. I would like to focus on one thing here. Your SOP, while designing your standard operating procedure for a particular department, you will be focusing on the clinical services part, because how do you do the initial assessment, how do you do the documentation, what is the mechanism for follow-up and reassessment of patients, what is the treatment plan or care plan as per needs, this will all be included in your standard operating procedure. SOP the loin yarga line. So there is whenever, please remember, whenever they say in NQAS checklist amada, please remember this, facility has a defined established procedure. Whenever they say facility has defined an established procedure and they ask for record reviews, you have to show it in your SOP. SOP the yaronga dauni ko sigi kenose. SOP the yaronga dauni magi. Whenever they say established procedure is there, then it has to be in your SOP for any particular department. So E2, the initial assessment, documentation of initial assessment, history taking, provisional diagnosis, everything written, follow-up and reassessment of patient, treatment plan, all those things comes under E2. If they mention established procedure, your SOP the adugi E2 gi part se SOP the yaugada havane ko. And please don't worry about SOP. As I have said earlier, SOP is already framed for all the departments. It's just that you just have to customize it as per your facilities workflow. Example lama yeng se checklist district hospital gi IPD. District hospital IPD gi E2 se. E2 of district hospital. What does it say? It says the initial assessment of all admitted patients. E2 talks about magi ngasagi haiba clinical assessment, reassessment, and treatment plan ki preparation ko. Initial assessment of all admitted patients is done as per standard protocols. Standard protocols hai akoina kenoda dum SOP da dum define taurani. Assessment criteria is defined. Assessment criteria is defined for different clinical conditions and measured in the assessment sheet. Patient history is taken and recorded. Please note this is record reviews, which they will check from the OPD register as well as the prescription sheet. Physical examination is done and is recorded. They will see from the prescription sheet or the OPD register. Provisional diagnosis is recorded. So these are all you will get 2, 2, 2, 2 if you just follow the prescription audit guidelines. So you can just imagine how much marks you can score without spending a single penny. And on some few capacity building of the medical officers who's working there, you can just straightway score like 10 to 12 marks without spending a single penny in area of concern E, that is clinical services. Now, about the procedure for follow-up reassessment of the patients, there is a fixed schedule for assessment of stable patients. Aduna, it is always a good practice, and it is there in your prescription audits as well to write the follow-up se karang kanda lakado bono habado prescription da yenghanba. Prescription audit kamain tawi natragana prescription se kayam yengdoino haitaragadi 30 yengdoino for any study, for any kind of analysis. For any kind of analysis, it may be patient satisfaction, it may be client satisfaction, it may be prescription audits, it can be time motion study, any whatever study we do in NQAS, the minimum number of subject will be 30. 30 Shudataragadi in a month. Let's say, for example, for a level of primary health centers, which Moida Kaigumba patients say tha amada 30 yaudraba. If they have only 10 to 15 patients in a month, adui taragadi sigi studies e tawba yade. So studies e complete oihan gai taragadi quarterly oina we will just accumulate 30 patients and then we will do that study. Aduna prescription audit tawge hai taragadi we will need 30 prescriptions, and out of those 30 prescriptions we will see how many prescriptions were there with follow-up advice, with specific follow-up schedule. All those things will be checked from the prescription, doctor's prescription. Now, this is about UPHCs. UPHC ki say, I think, like no mande, but just the UPHC ki checklist say they are beautifully designed. Adon ain sum yung hangena sum taw bane. It is similar to primary health centers. Also, patient history is taken and recorded. Examination is done and recorded. Diagnosis is recorded. GC means general clinic harmonica. Moigi di OPD high day, UPHC di OPD high day, general clinic high. Patient history is taken, recorded. Examination findings recorded. Provisional diagnosis is recorded. Referring system from OPD to higher center for specialist consultation. Khara ama prescription tara a prescription. Whenever we see about 30 prescriptions, some of the prescriptions referral tawagi so idan yarang gani adugi poto yengdoiniko. There is a system for follow-up of patients referred to higher facilities. Once a PHC refers a patient to a higher level facilities, then higher facility, the check how is the condition of the patient, that has to be checked by, that has to be followed up by the primary health center itself or the linked ASHA, ANM, whatever. Adugi kenoduna maze kenotau grabra. Treatment tawgrabra miron bi oitaragadi if maze higher center amada referral tawgitaragadi delivery tawgrabra, whatever follow up that is needed needs to be done by the primary health center or UPHCs. Prescription and treatment plan is documented. Check OPD script, check OPD slip. Prescription is updated for follow up visits. Follow up visits should always be there. Follow up visits should always be there in case of all right, standard E3. E3 is about interdepartmental transfer. As you can see here, it is applicable to all facilities, and this is about sub-centers. Applicable to all facilities like district hospital, PHC, UPHC, and CHC's interdepartmental transfer. Here also they have said defined and established procedure hai ko. Defined and established procedure hai taragadi SOP, the how do we do the interdepartmental transfer? How do we do the two-way referral? How do we have the caregiver follow-up of referred patients? How do we have the linkage with medical college and telemedicine services? This all should be defined in your standard operating procedure. So let's talk about E3. E3.1, 3.4 say interdepartmental transfer, two-way referral linkage. Continuity of care habeniko. I am seeing bio continuity of care, which is a very important term in case of NQAS. Care should be continuous from primary health center to CHC, from CHC to district hospital, from district hospital to medical college, from medical college to district hospital to downward referral like primary health centers tagisu downward referral to sub centers. After medical officer na tawgadaba thabak specialist na tawgadaba thabak singdo tawro matungda medical officer na sinarakpa medical officer na tawgadaba thabak loiraga CHO da sinarakpa, then CHO can again asha thadoga outreach chalan bayai, house to house chalan bayai, immunization specialist na angang puglaga ANM na yum da immunization tawba chalan nechi. So that's the continuity of care in case of NQAS. So next is about just kanoma yeng as we will just see the model checklist amakak in case of accident and emergency in the level of district hospital. The district hospital ki accident and emergency 3.1 the continuity of care se there is a procedure for handover for patient transfer for emergency to IPD and OT. Kaigumba accident and emergency department or trauma care center the patient to lakpa matamda there should be a procedure for transfer or handover of the patient from the emergency to the IPD or OT. Handover register is maintain to they will see the handover register, that is record reviews. Check how handover is given from emergency to the ward or ICU or SNCU. Kaigumba mayung the home delivery matawre haro na tagana samangang mapam atopa amada delivery matawre haro then angang do serious or higher, then they comes to the district hospital, gets the child admitted in the SNCU special newborn care unit. So there should be a transfer register or handover register at the heck as we system I think all the medical officers will also be knowing ki what all needs to be recorded like vitals or whatever need patient at the time of admission the need check this is also most of the time we will get to. There is a procedure for consultation of the patient to other specialists within the hospital. Okay, patient is referred with referral slip. Patient is always referred with a referral slip. In our facility, if we are referring our patient to a higher center, we do not usually use our prescription sheet. Rather, we use a prescription sheet. Prescription slip say it is best if it is color coded. Triage red prescription sheet for urgent, yellow for immediate, and green for green to the OPD basis so color coded referral slips are a very good practice, and it is mandatory in case of subcenters because subcenters ki level the always subcenters ki level the moina treatment tamlina moina referral oina dum they will need color coded referral slips. So okay, availability of referral linkage to higher centers. Referral linkages to higher centers it is not necessarily medical college ka khatang tawni haiba leite ko. Obviously for district hospital ki level their referral should go to institutes. Otherwise subcenter ki PHC ki linkage is good enough, PHC ki CHC ki level is good enough, and CHC level ki district hospital ki referral linkage is good enough. Advanced communication is done with higher center. In the OPD or emergency wards, our higher level tertiary care hospital ki phone number it is because in case of emergency, so if there is a patient whom we cannot manage in our facility, we have to just directly call the our referring facility patient for example in the level of PHC we have a case of snake bite, we have given 20 vials of anti-snake venom, we are sending you for further management at the minor. Then referral vehicle is being arranged, referral in or referral out register is maintained. Sigi referral in and referral out say it may not be two separate registers, but referral registers shemba matamda column amma hapa yai whether this is referral in or whether this is referral out. Admina referral in oitagadi in the out oitagana out. Admina column magasu it serves the purpose. Register yamakandana hena problem way. So if you can have two registers, referral in ki register tongana, referral out ki register tongana thamagadi, it's good. I'm talking about primary health centers and sub centers ki waniko. District hospital ki level that they might be having a different counters also for referral in and referral outs. But for the case for in case of primary health center gumba patient yamdava adumbai oitaragadi instead of having two registers, you can keep one register and then you can just put two columns. One says referral in and one says referral out. Date and time should be mentioned. What kind of cases are being referred, all those things will be mentioned. Patient demographics, vitals, treatment given, everything has to be written on that referral register. Sub-center ki level da, we see some points on case of continuity of care. As we can see here, it's E3. E3 Nico continuity of care say in case of other facilities, but it is E2 in case of sub-centers. So community health worker ensures home visits, counseling, supportive activities, risk factor modification, provide reminder for follow-up at client interview or record reviews. Household level the continuity of care toba. ID akona sub-center ki level dadi mostly community based oibanina moina hidak cha kiba moina hidak pi kiba moina treatment taw giba se moigi follow up se home visit na yamba tawe ko. So aduna ne household ki level da kumdhara is has defined protocols for referred out. It is there in your work instructions. Check availability of separate color coded referral slips. Color coded referral slips say Kaigumba, if the facility doesn't have that much of funds in sub-centers, it is mandatory to have referral slips, color-coded referral slips. Let's say, if Kaigumba color-coded referral slip laitabataragadi, in your referral slip, just tap a ribbon. Ribbon di thambiro ko. Ribbon thambiro, red ribbon thamo, yellow thamo, green thamo, and then just staple that ribbon so that anybody na yengba matamda yellow ribbon oiramagadi adum yam kana emergency oidre hain emergency oida taragasu immediately the natti na hain then red oiragadi yam urgent na hain. So just staple one ribbon, colored ribbon like red ribbon, yellow ribbon, or green ribbon advaina. Then facility has defined protocols for referral in. Check the records of treatment plan, periodic assessments. Sigi mayam se when they ask for your record, you can show them the register in which name, age, sex, address, diagnosis, adumba mayam iramani, aduga referrals smaina in out and thamo referrals manung the lapo itagadi manung the then referrals mapancha kibogadi smaina aduga remarkta where was it referred from adugi mayamdo ibiramo, and that will serve your purpose. Now comes the E4 ko. E4 is again they have established procedure SOP the hapo panesiki. Then it is about nursing care ki patient ki ID band se kaigumma in the level of district hospital. I request kitang kaithopiraga patient ki ID band thambiba ko patient ki ID band se laibiba. It is available in online Amazon gumba kaigumba the patient ki band yam yon bani, and in Imphal or in the valley area the Imphal the natragazu in valley area the wherever NQAS implementation they have started using the patient key ID bands Amazon da dum bane yam kana tang mazu oide ko. Timely accurate nursing care as per plan, monitoring the TPR about the nursing care niko. This has to be nursing care se akoina mark phajana phangbe ai, provided all the nurses should be trained by the medical officer. Moina tawgadawa thabak mayam se standard operating procedure si yengbagi standard operating procedure da akoina as per SOP tawbagi yam kanaba amana, it is all uniform. step number 1 dana aduni, step 2 dana aduni, step 3 dana aduni, step 4 dana aduni, step 5 dana aduni, and then it is done. Sigi potse SOP da iribado aduga chamanana tautaragadi, no one will forget. So SOP da yam phazana frame tauraga. If we train the staffs as per the SOP, then no steps will be missed. There will be very less negligence. Head lakpa matamda vitals on the vitals olaba matungda maze triage tauthokpiba bu oiro emergency da natragana OPD ki case dana aduda chalanba. If sigi matungda magi sigi ban hapchanba inpatient da admit tawdoragana si tawgadawbana, if we follow just one simple process mapping, then it becomes very easy. That becomes negligence ki chance yam thina name, because we follow certain steps. Step number 1, 2, 3, 4, 5, 6 ana like hitaragadi efficient oibe heli, then negligence ki chance yam name me badoi taragadi kaubugi chansu handheba. So these are all the standard operating procedure to the loina yauraga laire, and it may be different from one facility to another. So that's why some kind of customizations is needed facility to facility. Arm sub center ki nursing care ki matangda, nursing care at arm sub centers process is there in place to identify and monitor patients. Adequate forms, formats and records are available. Sub-center ki level dadi, they do not moina subjectively, they do not design anything. It is always a template. Moigi kenogi CBAC form membagi bu oiro, mental health ki examination tawbabu oiro, elderly ki examination tawbabu oiro, anything tawbase moigi di template amamam form tawi masana kashu tawbagi masana shemba yawi yawde habanate. But then formats, templates, all are available so that it becomes very easy for the CHO to just fill up the form. Anything prescription nama iba so form fill up to by time ihallebuko. Just like akoigi keno the so labor room ki records mayam se moina maternal health division na koina magi keno objective oiba akoigi template amamam da loina melhan bado maina sub center gi. So for everything they have a specific template starting from your prescription sheet to the discharge sheet to the referral slip to the CBAC form, family folder, your mental health key checkup, screening, everything forms and formats are all available so that there will be minimal negligence. District hospital IPD ki parta nursing care ki point khara yeminasi. It is about nursing care at the district hospital in the IPD department. There is a process for ensuring patient identification before any clinical procedure. This is, they do not ask for any records in here. They will just ask the staff who was posted on duty, how do you identify any patient? Or kaigumba patient ki makhutta ID ban yauram taragadi, verbal confirmation of bed number kai yauba ID ban yauram taragadi, self-explanatory oire moi identification of patients before admission se tawe habagi ko. Treatment chart is maintained. Treatment chart se maintain tawe ko. Treatment chart maintain tawe na ko every patient amamam gi page amamam sister gi station to the leram gani file amamam gi manung da magi TPR chart adai magi intake output adugi chart mayam do loinamak iraga leram gani. Drugs given are marked. There is a process to ensure accuracy of verbal or telephonic orders. Check system is in place to give telephonic orders and is practiced all the time. Doctor available oidabaya aduna telephonic order lowbagi provision thamgadawni. At the same time adugi telephonic order do kona akoigi written order the onthoknanabagi mechanism su yawgadawne bako. So okay. So patient handover is given during the change in the shift. Sugumba mayamse all part of nursing care. I would also like to introduce the Yaudre, but then it's okay. Aquina, there is something called as the BHT. BHT is bed head ticket. When you start assessment, BHT is mafam khudingmakta yam thengnarakani in case of primary health center, primary health center, UPHC di yaude. CHCs, the district hospital, you will always come across this word BHT, bed head ticket. This is very, very important. Assessor will always see inpatient magi every bed ki magi mamangda board amamam hapaga magi nungti medication magi vitals magi everything related to the patient adugi bed head ticket to the iram ganebako adugi bed head ticket se kaigumba yauram taragadi all this adum mark se phanganeba bed head ticket to the loina iram taragadi self explanatory oire what all treatment is being provided kari disease ki lairibano ngasi kaidogre adugi mayamdo BHT or bed head ticket to the loina mak iram ganeba. This is nursing care in case of PHC ki labor room ki department da. Labor room ki department da what all nursing care needs to be done. There is a process for ensuring identification before any clinical procedure. Sisu chamane ko identification tags, mother and baby footprint are used for identification of newborns. Treatment chart is maintained just like akoina sida high kibado dumaina chapmanana treatment chart is maintained. There is a process to ensure accuracy of verbal or telephonic orders. Labor room dasudum verbal orders are rechecked before administration. Patient handover register is there. Nursing handover register is there. Patient ki handover register, nursing ki handover register. Sugumba mayam say it all comes under nursing care plan of area of concern C, that is clinical services. Nasaidagi clinical services mayam say yeng birakoma tamda everybody must be doing. I think you all must be aware ki it is all process. It is all process, and NQAS is process driven standards haibado process ngaktani ko sigise sidai atopa paisa changningai natraga semba saba hospital gi beautification gi kai ka ambau yaude. It is plain akoina piriba service to soidanaba quality service piba with proper documentation pi taragadi we get lots of marks in area of concern clinical services. Subcenter ki level da amuk yengasi about the nursing care both in arm and home based investigation. Refill of medicines hai ko akoina kai gumba. For example, a person is suffering from diabetes and he needs to take the medicines daily tawbodo tha khudingi moina akoina tha khudingi subcenter na moida state ki supply dagi laiba NHM supply drugs mayam se moida piba ko adugi pibado once registered tawgraba matungda monthly gi piba se we call that refill of drugs. Refill of drugs hana adum aidi tha khudingi moida magi drugs sing do refill tawbirambagi mawong dani ko. So patient tuna laakanda subcenter dagi laujaba ama natragana koida ada chalakanda pibiramba ama. Same thing for nursing care in case of palliative care. Palliative care gi house to house chatpa matamda moigi keno lokthopiramba infant moigi sorry feeding tube riles tube lokthop change tawbiramba catheter change tawbiramba dressing tawbiramba adugumba it all comes under nursing care. Process to identify the non-complaint patient in chronic diseases. Kaigumba patient follow advice fazana follow up tawdabasingdo adugi list adugi management. Vitals are monitored and recorded periodically in follow up. All these things will come in akoigi kanodagi loi yengani ko sidi akoigi magi home visit ki register bu oigera akoigi OPD register oigera clinical register oigera in case of sub centers. Then E5 talks about, E5 is only for district hospitals and CHCs. It is not included in primary health centers and primary health centers. E5 is about vulnerable cases ki identification of high risk cases, intensive monitoring HIV and other infectious cases. It deals with vulnerable cases, high-risk cases. High-risk cases say akoina pregnancy da ayamba pregnancy da dum yengi ko high-risk pregnancy. Then intensive monitoring of those pregnancies. Kaigumba in akoina Pradhan Mantri Surakshit Matritwa Abhiyan PMSMA tawba matamda we identify the high-risk pregnancies on that day. And then high-risk pregnancies in the register amada ishan bigrani phone number lobby horani, and then we continuously we monitor them until and unless they get their baby delivered in an institution. We say sub center ki level dagi adum moigi keno je haurani ko sub center ki level dai moigi follow up se adum haurani if somebody is suffering from hypothyroidism or gestational diabetes mellitus, or somebody is short stature, or somebody is elderly primary, grand multipara anemia, anything adugumba laiba mayam se we will keep on akoi moi angang se poktri bhoba follow up tawi haibagi high risk registers daista akoina show tawdoine. Then for in case of district hospital ki IPD the vulnerable patients ki matang da yeng se for vulnerable patients check the measure taken to prevent newborn theft, sweeping and baby fall. This is for IPD ki niko sige vulnerable patients ki. Then high-risk pregnancies are identified and kept in intensive monitoring. List of cases identified as high-risk. Sigi pot se akuna register ama sembirani. Check with the frequency of observation. Its stage half an hour and second stage every 5 minutes. Sigi is in a district hospital. The high-risk pregnancy do admit taurak pagi wari niko. Aina ngasai follow up tauba yumda akuna phone tauraga follow up tauba mi tharaga follow up tauba haiduna sub center gi level gi nebu. CHC identify and communicate the category of patient considered as vulnerable populations, vulnerable patients. CHC identifies general administration. General administration in case of community health center, CHC identifies and communicate the category of patient considered as high risks. So these are some of the examples that is included in the checklists regarding high risk and vulnerable patients. Mostly Nasagi Kenoda, district hospitals and CHC. Now let's see about E6. E6 about rational use of generic drugs. Akoina prescription ibamatamda generic drugs, rational use of drugs, use of standard treatment guidelines, availability of essential medicine list, and bedhead ticket or OPD ticket. This is about akoigi generic drugs and their rational use. Arm sub centers the medication review nama tawe medication review se na arm sub centers the kaino hai kanda if a patient is, for example, let's say diabetes oiraga ma se district hospital amagi nang sigi hidak mayam se charo sub center da chatlaga sub center da gi hidak mayam se lawruru na thadore aduga sub center da gi man hidak se sum lawraga sum chareba ado sum chaga leiba yadeba annually or 6 months khudingi medication review na ngasai doctor do amuka chatlaga ai 6 months ki di sigi hidak sing se chare ado makhata na si cha hidra aigi improvement as mind laire ai phalak tabana sumain laire haibana medication review ama at the level of medical officer, specialist or medical officer trained in that particular disease adugiduna medication do review to biba machangeva. That is the medication review. Facility khudingmakta generic drugs prescription da ibigadawni. Even in pharmacies, whenever you store medicines, it should not be state ki supply the brand name yauba pishalak yawe kaigumba akhona. For example, metformin se gluconome supply the pishal e haragasu gluconome do akhona g da thammoeba ko we will sort it, we will keep it at M. Metformin the thamneba akhona always pharmacy da su whenever we keep the medicines we keep it as per generic name. Then check for singasagi bedhead ticket have it. Let's see district hospital ki checklist ta IPD department ta we see what is needed for rational prescribing and use of medicines. Bedhead ticket to the taklona yengba matamda ngasai phamungi manakta leiramniba ngasai board to the hida karam chari yengba matamda all drugs are supposed to be written in the generic name. check that standard treatment guidelines are available at the point of use ko sidai yamna akhoi gi gray area ma haizage standard treatment guidelines say it should be available at the OPD counter or doctor gi manakta laigadaune ko aduga sigi check the staff is aware of the drug regime and doses as per STG se sigi pot sidi check to boy am lui ko sigi pot se most of the time it will not be checked but kaigumba staff that directly koigi assessor hangbagi mawanda right lay but most of the time this is neglected because akoina whenever a specialist writes a medication whenever a medical officer trained in particular disease or trained in particular field writes a medication then we have that respect ki chuma manena adu the challenge kanamtana assessor na tawgande ko sigi parts so availability of drug formulary the drugs which are being written by the medical officer or the specialist adugi drugs to the akoigi essential drug list yawbodu ibira kanda the pharmacy da phanghangado pharmacy da phangba hida oigadawnen ado I kanamtanga haijage maraksida as per lots of meetings conducted about essential drug list and this writing medicines for generic drugs moina sida amakak haiba ko standard treatment guidelines ana essential medicine list say 80-90% of the time essential drug list designed to matamda it is designed as per the standard treatment guidelines aduna moina standard treatment guidelines follow tawbra hanga ise if standard treatment guidelines follow tawtaragadi the drugs itself is there in the essential medication list for example in case of diabetes we specialists na for the betterment of the patient hidak akoigi standard treatment guidelines the yauribadudagi hena phaba thabiramba yauramgani aduga adugi potudi essential drug list di chandava so what they are saying at the public health facility amadadi moina haise if kano oitaragadi mi do koina leiba ngamjagragadi phare if not standard treatment guidelines the yauriba essential drug list the yauriba hidak to thabiyo habune aduduna ne ngasai moina standard treatment guidelines the aduga akoina state or sigi committee the akoina sigi hidak se hapchanbiyo hairu matamda if it is not in if that particular drug is not included in the standard treatment guideline they will not include it in the essential drug list adumaina khara ma hainai ko so complete medication history is documented for each patient name confirms patient name prescription details medical history drug before administration all this sigi se IPD da akoina ye ni ko PHC gi IPD da just kano khara checklist ki about kano khara drug administration and standard treatment guidelines ki rational use of drugs ki kitang yeng se administration of medicines done after ensuring right patient drug route time documented 7 hours and or 6 sorry 7 hours for district hospital level and 6 hours for sub-center level right patient right drug right route right time right documentation right reason and amasu yawbaniko so see is 7 hours 7 hour of medication safety ne right patient right drug right route right time right documentation patient is advised by doctor nurse about dosages and timings patient ta hangdoini go sigi sidi natragana magi patient ki akoina record on a show to haita gadi patient to da akoina explain taw gibado sigi keno mayam si explain taw gray hana akoina magi keno da che da ibiramba ama natraga idragana patient masamak to da hang gitaragadi dum patient explain taw re haita gadi okay sigi pot se like patient is advised hidak se karan kanda chadoino hidak se karan kanda toktoino habase it is asked to the pharmacists also pharmacy phami ba mi du da su assessor na changa kanda pharmacy du da hidak leiram mi ba patient amada changa kanda nangi pharmacist na karan kanda chani sigi se explain tawra abra na hangne that comes in the checklist for pharmacy it is there different levels tagi pharmacy dagi su doctor gi level dai su doctor ngamdragana sister gi level dai su patient sing se assessor ne hekta pharaga sigi hidak se nangona kamain chani je pharmacist na hairak pra doctor na hairak pra nurse na hairak pra dum hangine buko So check for bedhead tickets if drugs are prescribed under generic name only. It is same like district hospital. Like PHC is a rational use of drugs. Check that relevant STG is available at the point of use. STG is a अखोना OPD की counter अखोई की consultation room the STG से लोइना मा printed copy से थमता रगदि अखोना अदुगी दो follow तवे हाइनसु खन्नई को आम सब centers ता check the cases in which CHO has prescribed medicines or antibiotics. Sige me hamse subjective hoina dum yengdoine ko karam bada kona ma p de give non-compliant check high n or more than one antibiotics is prescribed. Give non-compliance if any of the above 0.2 or 3 is yes. Si natraga si kaigumba tawram taragadi अखोना सिगी मार्क से कनो पीरोय हाबनिको मार्क पीरोय हाबनिको कईगुंबा सी नत्रगा सिगी अनी सिगी मनुंगदा अमा तौरम तारगदी check availability of STG clinical algorithm IT based staff is aware of drug regime and doses sidi dum staff interview tawbada dum khangani ngasagi medication review aina ngasai ama haizabado in case of if a patient is suffering from diabetes and he has been having the medicine for 1 year, and it is time for him to get his medication review done with the specialist or any medical officer who is trained in that particular disease. Then comes the E7. E7 is about safe drug administration. Safe drug administration, the I know who's have 7 R's. Right route, right patient, right time, right dose, right documentation, right reason, all those things. Medication orders are written legibly and adequately. I request all the medical officers, all the specialists to follow the prescription audit guidelines and please start writing. Yam chinta agasu at least practice the prescription audit tauba yananaba prescription khara amadi capital letter di ibiyoba. Rest isagi practice ta iba me amdo. Please continue, but Horen quality team na prescription audit tauge na prescription khara laukhat padudadi. Those prescriptions, please make sure those prescriptions are as per the prescription guidelines. In that prescriptions, please write the generic names. Please write in capital letters. Please sign with your name. Please sign with your date, time, ticket kakpa matamda so computer na kalagadi phare. Otherwise, please make sure weight of the baby is written. If it is less than 5 years, 4 years and 3 months, months also should be written. Allergies are supposed to be included. Follow-up advice is mandatory. Aduna sige mayam se as per the prescription audit ki guidelines the follow tauba prescription kharadi always tha khudingi thambiyo bako. Then high alert drugs. High alert drugs, mayamama lay. I will show you the list of high alert drugs which is applicable in higher level facilities or secondary level facilities. The high alert drugs which are applicable in the primary level facilities. I'll just show you. Expired drugs are checked. Expired drugs hairagadi expiry loy gibadoni. Near expired drugs hairagadi 3 months ki manungda expiry oigadoba drugs mayamdo adubu near expiry drugs kawe. Near expiry drugs should be returned to the manufacturer, either returned to the manufacturer or it should be kaigumba mana nakpa jaga amada adugi poto laitata agadi akoina peer primary health centers or peer community health centers the yenthokibe or sub center the yenthokibe, but please make sure near expiry drugs mayamdo pairaga thambiga novoko. So those are expired and not near expired drugs may amgi matangdani. Counseling of self drug administration. Self drug administration, the 5 moments of medication medicine administration, and I'll show you. Then see arm sub center the 5 moments of medication safety. Sige siniko 5 moments of medication safety. Sige sina what akoina moida haibi gadois. 5 moments of medication safety is not for the hospital, rather it is like a counseling, like an advice to the patient. Starting a medication, haitaragadi kamaina medication do, how do you know what is the name of the medication? Kari dobogi charino kar, haidi kai dobogi no chaba how we say what are the possible side effects, all those things in it's the starting a medication. That is the first moment of medication safety. Second is taking my medication. Taking my medication, say when should I take this medication? How much should I take in each time? 1 tablet once daily or 1 tablet twice daily. 2 tablet twice daily, 2 tablet thrice daily, 1 tablet 4 times daily. Adugumba mayamdo haibiyo haibanebo. Then adding a medication. Kaigumba akoina paracetamol ama charing ida montelukast levocetirizine ama hapchan bamatamda adugido kamaina chadoino. Do I really need the other medication? Aduga adugi medication do add tawbamatamda karam kanda tawdoino. Then medication ki interaction mayamze moida haibiba. Then reviewing my medication. How long should I take each medication? For example, allergy gi akoina 1 month hida ama charo na haire. Then that medicine do adugi matungda review tawbo amde changidana. So that is about reviewing the medication, and at last maze pharakanda stopping the medication or tapering the medication, whatever it is, adugi advice to PB doineba. So that is 5 moments of medication safety. This is very, very important for sub-center ki level. It is equally important for district hospital and PHC levels as well. But then assessor na hangba matamda sub-center, this is one of the favorite questions for assessors. So these are the high alert medications. These are the high alert medications for ISMP ki list. The high alert medications mayamama sumaina P ko. These are all high alert medications. High alert medications hai taragadi from that moigi maximum dose adudagi helagadi koigi haksang da adverse effects mayamama tho a haibadugi idea daniko. So these are high alert drugs ne na koina utpa yai, but at the facility level, what we have to do is we have to show them the dose also. Like these are the high alert drugs. These are the 40 high alert drugs which are which should be pasted in the primary level facilities, including sub centers, and their maximum adult dose. Shidagi di henba yade habaduneva. Shije thetkadoineva. Koina, and we should be aware of it. Then safe drug administration. Every medical advice is accompanied with date, time, and signature. Akoina yam lai na akoigi prescription audit tawba matamda doctor na yam phajana iramen khalase, but most of the time they miss signature along with date and time. Aduga follow up ki advice ka allergy ki records siga. So adumba assessor is coming to adumba haidi awat apa mayam do phat yin danada la abanina, they will just find out ki mayam na toina soiba pot se dum uba phangane buko. So audit tawba prescription audit ki matang da, so I request the district team to kindly have a separate training on prescription audit so that akoi ki doctor mayam gi actual practice ta mak implement tawba ngam da taraga su to have certain prescriptions which is actually as per the prescription audit guidelines. Drugs are checked for other inconsistency before administration. Single dose vial ampules are not used for one. Sugumba mayam sidi, it is always observation in staff interview. Hangakani sister na kumbirani, that's all. Now let's go to medical records. Medical records. What we are looking for is, it is in all facilities: assessment, reassessment, investigations, treatment plan, chart registers, procedures, sugumba medical record storage and safety. We have a special district hospital level da, we have a room called as the medical records room. PHC ki level da, so medical records mein aange section number thambi pe hai, on which there is an almirah, multiple almirah lai rekho aduga thana April vaina tharakanda file tape tor hainam thambi, all files mein aange tape thana the April 2025 shi thambi shi nakanda mo tape tor pulla kanda thana March 2025 pulla kanda all magi OPD gi keno mayamama IPD gi mayamama adugumba treatment chart mayamama every patient ki March 2021 the yengi ba patient mayam gi file pull up tape tora kanda adumaina thambi. I think this is being done by the sister in charge or any multi-purpose worker in the district hospital tauramgani na khalle aduga tauda taragadi please akoina as per the medical records policy sugumba mayam se all 3 years, at least 3 years ti loinamak thamgadawne na hai aduga disposal se so 3 years thammakanda records ki policy have a storage policy have a maintenance policy have a disposal policy have a tongan like medical records ki. So there is a different policy for maintenance, there is a different policy for storage, there is a different policy for disposal. So disposals in a Canada hide kanda karai the kamaina disposed of, that is another policy that needs to be a quick da a quick NQAS ki documents submit the loin yaurakaniko the gimeamdo. So district hospital ki general administration ki part ta hospital has a separate policy for retention period for different kinds of records. This sige se akoina ministry dagi le ministry dagi akoina order ama lai all magi keno me amse keno koi records me amse at least 3 years tham gadong ne na. Not only 3 years akoi gi atopa ma adu da palli se different palli ko IPD gi na adu tham do ba adagi OT gi paper na adu adiam tham ga do ba ko ka do ba adu da loini yawe ko that can be shared adu ga adu gi do dum akoi na hospital gi retention period ne na adu ut pa yai but akoi gi policy for safe disposal of records like ga do bani na hai ko safe disposal of records say it will include storage, maintenance as well as disposal of records. Sigi ahum sigi policy ni ko yarakadoi. Then PHC gi IPD ama yengsi, it is IPD about updating patients' clinical records and their storage. Day-to-day progress of patient is recorded in the bedhead ticket. Nasagi bedhead ticket I have SSR at any point of time the lakpa matam the magi bedhead ticket si yengba matam da ngasigi kari hida kap kre ngasigi advice na kaino magi vitals na kaino adugumba mayam do loimbak bedhead ticket agi khangdoini. Treatment plan first orders are written on the bedhead ticket, any procedure performed written on the bedhead ticket. Sigi mayam say bedhead ticket akoina phajana maintain tawita gadi we all get full marks in here without spending much amount of money. Temperature chart, intake output chart, treatment chart, all those things, general order book, report book, admission register, lab register, admission sheet, bedhead ticket, sugumase general IPD the registers and records are maintained as per guidelines. Aduna IPD the mayamna kaigumba kai register no khoina maintain tawdoi se in case of PHC gi IPD amada haitaragadi we can take the NQAS checklist itself as a guideline. Sigi mayam se yaw laitaragadi almost cover tawre na dum lawaya what all registers needs to be maintained in case of IPD at the level of primary health center. Now arm sub centers ki na amok ngasai gi clinical records ke mayam se diagnosis, assessments, treatment plan, drug prescribed, follow-up recorded, all recorded for all cases by health sub-centers. This is record nangi the prescription sheet mayam nangi record mayam thamiba register mayam thamido adudai gi thum utpayarani diagnosis, assessment, treatment plan for RMNCHA gi sina curative ki akoi gi the arm sub-centers ki service provisions. If we remember, the first one is the comprehensive primary healthcare services, and number 2 is drugs and diagnostics. Other than service provisions, the Europe curative services have RMNCHA have aduna curative key services ki simyamjima thambiraba, then RMNCHA ki simyamsi thambiraba, then that's it. Makadum full pan. All facilities assess the patient readiness, discharge of the patient like last part of the general clinical services. General clinical services part A gi last part, that is the discharge of the patient. Assess patient ki readiness, case ki summary ready oirabra, follow up instructions yaurabra, counseling services yaurabra, declaration record lama patient lawaris patients, absconding patients adugumba mayamdo. In case of counseling se miron bigida di counseling yam depend tawi adolescent ki yamna depend tawi counseling gi rule yam chawna lay aduga it has to be written very clearly in the akoi case to the su by akoi sister duna ni khangdi ama ni khangdi counseling services se phajana pb ba ma changeba. Just an example, exclusive breastfeeding gi, nutritional gi, after delivery the family planning services ki counseling piba, nutrition gi counseling, calcium chaba, iron chaba, family planning gi adugumba mayam do loina ma counseling se pi haibagi koida evidence to laibam change buko. So about discharge of the patient, first is assess the readiness of the patient. Case summary duma koina ready to birani, follow up instructions ama happy rani, counseling services aduda yaw kano to birani, counseling services tuma koina issue ibirani patient the high birani adugumba mayam gi separate checklist la angani adu ka discharge ki do yam simple oiko. Then comes the part B, which is specific clinical services. Let's take a break for 2 minutes, please. Okay. So area of concern E, as we have discussed earlier, it is divided into 3 parts. The first part is the general clinical services. Second is the specific clinical services. And the 3 is RMNCHA and national health programs. So we go to the specific clinical services, that is part B. Sorry, part B, the we standard 10 to 16 lay 16 sigi matung dadi RMNCHA lakpani, but hemodialysis was added later. That is why 24 analyze iniko. So specific clinical services is 10 to 16 and 24. 24 is hemodialysis. Hemodialysis we will not go further details the changaroisi, but let's discuss few things about standard 10 to 16. That is ICU, emergency and disaster management, the diagnostic services, blood bank and blood storage unit, anesthesia unit, OT, end of life care, which is basically checklist which is found in mortuary, and last the hemodialysis. ICU, as it is written here, it is not it is not included in the checklist for CHC. So standard 10 say standard 10 the young but it is not ICU for the level of CHC because CHC the ICU kwena tham debuko. So E10, that is intensive care unit ICU. ICU the procedure for shifting the patient to step down or ward based on explicit assessment criteria. If you remember, has an established procedure. Sigi it should be there in your SOP. Shifting of patient to the step down or ward based on explicit assessment criteria has a defined and established procedure for intensive care, explicit and clinical criteria for providing intubation, extubation, care of patients on ventilation, and subsequently on its removal. So the shifting of patient, intensive care unit ki magi procedure aduga intubation extubation ki adugi matanga. So we'll just see in case of emergency and disaster management, that is E11. Yam sigi po I checklist di changaro ke I'll just kitang brief oina hairage because these are very technical ones and sida akona assess tauba hai se khoi gi clinical oiba ngasai gi ICU da actually clinically tauba pot mayam to the oina based away. So nothing much related to quality. It is much more related to their clinical or technical expertise. Then emergency and disaster management, there is a procedure for receiving and triage of patients. Emergency has implemented system of sorting the patients, number one. Number two, the triage area is marked. Number three, the triage protocols are displayed. Number four, the responsibility of receiving and shifting the patient from vehicle is defined. All this are included in the SOP. For example, let's say this is the triage protocol. Triage protocol se kai the thetkani triage ki room the thetkani OPD the thetkani emergency the thetkani triage se patients in a hana la aba matungda they will do the triage and then they will go to the registration counter. Because triage akoigi patient amakhak emergency masana oi khangdabida oiraga registration counter da queue leptana leramagadi, that is a huge negligence. So triage hana taraga in case of emergency and emergency accident and emergency or trauma care center then triage hana taraga, then they go to the registration counter. So this is the triage protocol. Emergency and immediate, that's red. Delayed is yellow. Minimal is green. Expectant is blue. And dead is black. Sigisina ngasai magi NQAS na piba triage protocol do nebuko. So this sigi triage protocol itself sigi potse adom akoina anywhere da thet pa. But triage say it is akoigi angangi tongana ahangi tongana adwaina thet pa. That is also a good practice. But as a common, we can have this triage protocol displayed in our facility at the triage room or accidental emergency area. So triage of patients ki di implemented a system for sorting the patients. Triage area ma thamani, counter am thamani. Triage protocols are displayed. Responsibility of receiving and shifting the patient from vehicles se it is defined. It can be different from one facility to another, but then that has to be defined in the standard operating procedures. Now, emergency protocols are defined and implemented. Emergency protocols are available at point of use. Emergency protocols ki IEC mayamama laiko IEC material mayamama for accidents and emergencies mayamama lay adugi mayamdo koina emergency room da thietla kanda thammo haibani thietla gadi ko implement tawina dum lobo yai ko. Then koina moina yam kupta kupsala gadi they can see our akoigi emergency gi treatment ki sister gi register do yengakanda what was done adu do yengba yai. But then if we have the specific protocols IEC materials displayed in the emergency area, then that itself is it means that it is implemented in the facility. There is a procedure for CPR tawagi staff ki knowledge aduga magi IEC materials display tawba aduga adum CPR is very important at the level of sub-centers or at the level of district hospitals or PHCs or CHCs. Moise adum any doctor didi angkan hangoi, but all the staff nurses, all those paramedics moida CPR to haina moida kano se display demo tawana to halakane with embu bag. Then E11.4 is how ambulances are called and patients are shifted. Ambulances are equipped. Aina nahan district hospital gi the district hospital gi suggested departments for NQAS certification. The aina hapta base ambulance ki accident and emergencies aina hapta base because they give a lot of emphasis on ambulance. Aduga ambulance ALS oiba BLS oiba at the same time paramedics or medical officer staff nurse loinamak manung da yauga da une habada manpower gi issue laita ragadi ambulance ki part se akoina compliant pi base waiba. But adugi do laita ragadi beautifully set up toraga laita ragadi it can as well apply. But accident and emergency is one department that's a little bit challenging because a lot of HR is being needed. If a patient is stable, then he is transferred in an ambulance. Patient is serious as decided by doctor, trained driver one paramedic staff is mandatory to accompany him. Patient rights and responsibility to the yare. Ambulance appropriately equipped with BLS and trained personnel. There is a daily checklist of all equipments. Ambulance has a logbook for maintenance of vehicle. Transfer register is maintained. Medical legal cases about emergency and disaster management. MLC MLC fazana akhona maintain tawba emergency is criteria for defining medical legal cases. So this I won't go into details, but just this is the basic idea of how emergency and disaster management is within the specific clinical services. Now, disaster management say at the district level, a disaster management committee, give me one T. Disaster management, so the availability of a disaster management plan. Disaster management say committee di at the level of the district disaster management committee di form tawraga. We have a disaster management plan, facility level disaster management plan. Is it in sync with the main disaster plan of the area? Disaster management plan of the district tuga, disaster management plan of the facility tuga, manabra. When was it last revised? Revised to the toes. We'll just frame it and keep it. Are the facility personnel aware of their roles and responsibility in the event of disaster? Disaster management committee shemba matamda moigi roles and responsibility defined the and a mock drill at the level of facility. If it was conducted, we'll get more marks. Diagnostic services. Diagnostic services, especially in cases of laboratory and radiology. Diagnostic services say atopa area like labor room, like IPD or like maternity OT da yawe. But then adugi mayam duna amo okogi kit based kumba point of care diagnostics kumba adugumba duna ayamba oeba ko. So testing the diagnostic services, we deal with the pre-testing activities. Lab ki parts hai. If anybody is posted in the lab, out of all the participants today, lab ta laiba yaw taragadi lab ki se kitang adum kano oi ko kitang tricky oi because akhoi external internal quality assurance tawgadaba pre-testing da akoina tawgadaba port mayam ama post testing da tawgadaba port mayam ama yawe. So sige please hasan id kitang attentive oina tabiu. Diagnostic services, we divide it into pre-testing activities, testing activities, and post-testing activities. Pre-testing activities is all about requisition form dagi hauraga koigi transportation of the sample ngasai kano do the testing area do the p base. It is the pre-testing activities. Test to matam da testing ki part ta standard se yamde testing ki parts da is the assess mainly it is the pre-testing and the post-testing area where we focus more. Pre-testing, the requisition of all laboratory tests is done in the laboratory ki request form. If it is done through Krishna Diagnostics, it is okay, fine, moigi tonganba requisition format lai. But at the same time, there are certain tests which are supposed to be done at the district hospital. Moigi in-house lab to na su tawgadoba test emergency da mayamama lai ko adugi potudi akhoi facility ki level da tawdeya deb. Then instructions for collection, handling of primary sample are communicated to those responsible for collection. For example, in case of Krishna Diagnostics, kai gumba moigi keno se sample se kai gumba mayam moi Krishna gimina mayam laure, and then with moigi vaccine carrier or sample transport container ice packs ke hapakanda thamme manungi temperature kayano adusu akoina maintain tawraga thamni manungi temperature se kaya da thagi bano habidusu akoina igani aduga handling of primary sample se akoina moida communicate tawrni ngasi sample suppose 65 laire 74 samples laire etc adugi mayamdo collection lakadoriba mi singduda koina hana communicate tawbagi mechanism ma lairani. Laboratory has system in place to label the primary sample. Most of the times, barcode oiragadi khwaidai phare, barcode natragadi please make sure marker is available. Marker soidana hangakani. If barcode ding tawgragadi yam phare, computer printed barcodes lakhraba natragana computer printed kanu lakhragadi it's good. Otherwise koina assessor na yam simple as in your sample collection area marker pen puthoro na dum hayakane ko. Laboratory has system to trace the primary sample from the requisition form. Laboratory has system to record the identity of the person collecting the primary sample, that is the staff. Laboratory has system in place to monitor the transportation of the sample. Monitor tawba hai taragadi line listing ama semani every day if samples are being transported twice transport tawtaragadi magi temperature kayada akoina transport tawgiba. This is for those akoina krishna da tawgiba mayam dugini ko. Otherwise OPD gi area da sample collection tawbam dudagina labor akoigi laboratory bhoba chatpado adudo OPD dagi kaya thokibano labor room da kaya phangakpano sample da kayam damage tawi kayam ml kaya tawgadaw da kaya surai surakte bhail onadaba karamba color lakhiba karamba color na phangiba onadaba, that all has to be recorded in both the sample collection area as well as the lab. Then testing area, testing ki activities the, let's say what all testing activities the yam damni ahum khak laibani ko. But then in case of huren sigi sina clinical services ki part never, but in case of quality management part will be challenging because lab itself se akoina quality tongana quality tongana assess tawbam changi for internal quality assurance and external quality assurance that will be discussed in quality management part. So testing procedures are readily available at workstation and staff is aware of them. Sigi first part se I just want to highlight in case of tests which are given to the public private partnership Krishna Diagnostics, that is okay. Moina pigre moina test tawre badugi quality moina akoida pirakani sigi se akoina quality edu tawe kole na moina loi hairani, that part is fine. But there are certain tests which we do in our center. For example, let's say a peripheral blood smear is done in our facility. Krishna gida peripheral blood smear yaug dekho. Peripheral blood smear is done in our facility. Hemoglobin is done in our facility. Blood group is done in our facility. Hepatitis B, C, and retro is being done in our facility. Urine for sugar and protein is done in our facility. Then dengue is done in our facility. Sumai higher seva. All those tests, if we are doing 16 or 20 tests, if we are doing adugi test, every single test key work instructions should be pasted on the walls of the lab. Lab ta kaigumba akoina malaria test tawi hai taragadi, if we have the kit of the malaria, what does it mean when the first line comes out and the third line comes out? Adu itaragadi kari hai no, that work instructions has to be pasted on the walls of the lab. First means control, third means falciparum, second means Vivax, first and second that means Vivax positive, first and third means falciparum positive. If the first one is not there, it is a defective kit. Some adugi potse. Then RBS tawba matam dasu. When we do a test for RBS, akoina prick hana tawgadra natragana instrument to the akoigi magi keno do hana kit to hana injan gadra kit to hana injan doira prick han tawdoira, that all has to be pasted. It has to be prick hana tawraba matungda instrument to the kit to injan gadawni ko. So small simple things sugumba mayamum lakani adagi slide shemba kamaina shemba reagent kamaina thadaba car test ki oitaraga suna tragana serum dagi khaido okanda serum khaido okanda tawba test mayam gi acid fast bacilli yengbagi, all those work instructions are supposed to be for if we are in our in-house lab the case, suppose akoina in-house lab the case kun torsu kumanga torsu, for all those cases, for all those tests, work instructions should be pasted on the walls of the lab. Then work instructions akoigi keno da sudum yaudi yauzare ko magi akoigi kit ki box ki manung duda su magi manual yaurapado aduda su dum yaurapane, that also can be pasted kitang chautho halakanda adu paste tawba yai. Then laboratory has a system to review the results of examination by authorized person before release of the actual report. For example, akoina primary health center gi level da, if we medical officer in charge na tawba ama natragana, if we identify somebody who is responsible for viral hepatitis in the center, hepatitis ki reports mayam se the nodal person who is responsible for viral hepatitis treatment and control of that disease should be signing the reports. Report sign tawnanaba mi ma pameba, peripheral blood smear ama sign tawnanaba pathologist ama pami, culture gi report pinanaba microbiologist ama gi signature pami. So sumain tawdana there should be one specific nodal person who is responsible for that tests and sign tawnanaba haitare. Laboratory has format for reporting of results. Reports se akoina khutna iraga piba yade, it has to be printed, it has to be one specific format amada loimba pigedawni as per quality gi kenoda, quality point of view da and NABL gi point of view da akoigi sumaina, just like Krishna Diagnostics na piriba pula sequence the LFT gi marakta creatinine yausalakpa adagi KFT gi marakta thyroid yausalakpa adagi atopa da ani pula at one go the report ma'am low in the print was this is not acceptable. It has to be LFT one paper, KFT one paper, sugar profile one paper, thyroid profile one paper. It has to be separate. Eduga marakta moina remarks ke mama is between the nasagi lab ki format sida, between the magi each parameter dugi marakta remarks ishan baya devako. All data, all magi report mayam se loimba ira abu matung at the end part remarks should be written. Aduna, when you design a report if for your facility Krishna is okay, but if in-house lab amagi manung dagi thoklakado report pigi haitaragadi, please make sure it is in different paper. Laboratory has system to provide the reports within the defined cycle time of each category of patient routine and emergencies. In case of laboratory, please remember, laboratory say even if 24/7 ragasu, there are certain rules, at least 6 hours the hangdaba yade habini, 6 hours the hangdaba yade aduga 24/7 or 24/7 oigadawni aduga kaigumba sample collection gi times akona sample se thabanina, when a sample se transport oina tawbanina, we cannot be collecting the sample 24/7. So sample collection gi time ama akoina mayamda community da khanghanba, akoina akoigi test tawbagi time ama, akoigi turn around time ana masule akoina test ama tawba tamda pung kaya changba, emergency oiragadi turn around time should be only 1 hour. If it's just kano oitaragadi normal tawbo oitaragadi less than 8 hours ki manung the report piva ama adumaina pira kanda, it has to be pasted report collection time, sample collection time, sugumba mayam say it has to be all displayed. Laboratory results written in reports are legible without error in transcription. Laboratory has defined the retention period of disposal of used sample. Karang kan akona lab ta season ariba sample dugi retention period pun kya thamba yaba thambi thamgadau ni ko, retention period has to be there because akona kai gumangasi test ama tawraga if hayeng su amuk kaigumba test ama need oiraktaragadi maybe emergency da adugi sample dagi lauraga dum test tawbasu yai if the sample was preserved correctly serum khaidoga thamambagumba oitaragadi. So laboratory has a system to retain the copies of reported results and promptly retrieved when required. Free diagnostics initiative ta, as we all can see, subcenter gi level or arm subcenter gi level da 14 line 14 sigi manung da filariasis taude. Filariasis is not done, so it is 13. 13 so that includes iodine testing also, it includes water testing also, it includes sugar, urine sugar, then hepatitis B, dengue, all those things, malaria, all those things are included in this 14 tests. pH the yam khale 64, 97, 111. 6497 high say it does not include profiles or package. This plain urea, creatine, sodium, potassium chloride, SGOT, SGPT, alkaline phosphatase, urea, creatine, minor, oidoinico. Then district hospital gida 134. 134 gi manungda sigi mayam se loinama Krishna da tawe hai taragasu. This along with some tests which require pathologists are supposed to be done at district hospital and sub-district hospital ki level da. CHC dadi 14 khak tawe hai taragasu if it is a non-FRU. If it is a non-FRU, then sigi 14 se akoi in-house da tawi. Rest of the tests we send it to Krishna Hayasu Kashukaide, but district hospital ki level the pathologists are supposed to be there. SDH ki level the pathologists and microbiologists are supposed to be there. Aduna moigi test khara ada tawraktaba sida koina microscope ta yengaga tawba sing khara ama koina need way haitar. So these are the blood bank and blood storage services. I will not go into details for this, but key donor criteria, donor selection criteria, the standard amalai, then collection of blood key criteria amalai. These are all established procedure which is supposed to be there in the SOP. The Yaram Taragadi, we have the records for this. Established procedure for preparation of blood component, established procedure for labeling and identification of blood, established procedure of storage of blood like RBC na kaida store tauba, platelet na kaida store tauba, temperature maintain the wadu mamyam to yaura ani compatibility testing, issuing blood, transfusion of blood, then monitoring and reporting of transfusion complications. I will not go into details for this. If any district hospital is applying for blood bank or blood storage services, then we will talk about this. We will have a separate training for blood and blood storage services. Now, anesthesia services. If we are targeting for Laksha, then maternity OT is very important. Aduna OT the anesthesia changbanina. This is again important. Anesthesia gi the pre-anesthetic care has been done before surgery. Pre-anesthetic checkup ne monitoring during anesthesia ne post anesthesia care ne standard ahum lay anesthesia da pre ne during ne aduga post ne. Pre-anesthetic checkup has been done. Pre-anesthetic checkup has been done as per guidelines. Mangi iramba aduga pre-anesthetic se. In case of maternity OT, please remember there is a lots of means of verification on diet. How I did diet, karankanda NPO tham giva, karankanda muchaba yaba, kai cha giva, adugi mayam se, because they know in the prescription sheet, we tend to forget kanoda magi dietary advice mayam se, sigi se hapam da base, sigi pot se koi hapte khang banina, they will target that part also. Aduduna, please remember prescription even matamda nasagi magi dietary advices me amze kai chaga da ba kai cha wai da ba kai cha kiba karang kan phok cha ba ya da ba fasting for how many hours tham ga da ba adu gumba mayam gi advice need oi ba. There is a procedure to review the finding of PAC. Anesthesia plan is documented before entering into the OT. Anesthesia safety checklist is mayam ubira maniko. It is very important. Targeting Laksha, anesthesia gi safety checklist, gynae gisu labor room gisu okay safe birth checklist ana laiba lagi anesthesia gisu anesthesia safety checklist, surgery gi surgery safety checklist adumba mayam do I horen sida uchara ke ko adugi mayam do. Anesthesia equipments are checked before induction. Food intake and status of patient is checked. Patient's vitals are recorded during anesthesia. Airway security is ensured. Potency and level of anesthesia is measured. Sugum bamayam sida akoina means of verification checklist sida means of verification no impirang ganiko. Kai no mana sida patient ki vitals hairakpa matamda kari po no akoina check tawdoi se habase means of verification do the loimba pirang ganego. Anesthesia note recorded. Any adverse anesthesia event recorded. Sumaina. Then comes the operation theater. OT ki scheduling number 1 quite important oiba OT schedule numitugi the day numitugi OT schedule yenge ha kani last 3 months ki OT schedule yenge ha kani pre-operative care ne surgical safety ne post-operative care ne yenge. First is the OT scheduling, then pre-operative care, surgical safety, and then post-operative care. In case of operation theater, in case of district hospital, there is a procedure for OT scheduling. Surgery is my patient evaluation before surgery is recorded. Antibiotic prophylaxis given as indicated. Tetanus prophylaxis given if indicated. So we get lots of marks. Already hanadagi tauraga laiba puto ngaktani adudaiduda akoina tauriba put mayamdo kitang documentation amaga loina na assessor amada present tawbagi waneba. Surgical site preparation is done as per protocol. Surgery site preparation is done as per protocol. Say kashu assessor duna assess kano manungda OT manungda changaga yengadauba nateko. But then this is a staff interview question. Sister da hangakani, how do you do this surgical site preparation? Surgical safety checklist, I will show you. Sponge and instrument count practice is implemented. These are some things hana taurambasu tauramda taragadi tawba hobiyu. It is a very good practice. Instrument ki set ama puthorakpa matamda instrument adugi set to kanana yomamba no haibase adugi details like adauba. Kaigumba adugi set to gi manungda khulai machama yauram da taragadi instrument ki set shemase training amu need oire habeniko. So every set of instruments packed autoclave tauraga packed tauraga thamambasida adugi instrument ki set to da magi thambam to da karamba instrument no yauri sena thepa amasu need oebako. For example, in case of labor room, 7 trays like it 7 tray to gi manungda ani madi medicine ke oire, they do not need to be autoclaved. Aduna adum urani, but akoina ngasagi linen wrap tawriba tray mayam se adugi tray du manungda kai yawi no ase tray dugi mamangdo de thietla thamdoina. And then when we open it, we'll see if all the instruments are there. If any of the instrument is missing, we will know who packed it and sigi potse training dakar lai re haine ba kai gumba ngasai tray sigi manung the instrument se shuram da taragadi. Adequate hemostasis is secured during surgery. Appropriate suture material is used for surgery as per requirement. Check for suturing techniques are applied as per protocol. Post-operative monitoring is done before discharging. Post-operative notes and orders are recorded. These are all parts of process. Aduna documentation mayamama need way paperwork mayamama need way after akona surgery procedures tauraba matungda lots of documentations need way we should keep all the documentations ready, and it's a very good process. Sugumba surgical safety checklist if hanadagi implement obiramaga yam pai natragadi I would request to please start sponge and instrument count kumbasisu. It is a very good practice. Sigi sponge and instrument count ki practice se if you want to know the details, it is there means of verification the magi details yaw. Now end of life care and death, which is there in the mortuary checklist. If mortuary assess taudata ragadi may not be required. Death of the admitted patient is adequately recorded and communicated. Facility has standard procedures, SOP, for handling the death in the hospital. Standard procedures, SOP, for conducting post-mortem, its recording and meeting its obligation under the law. Standard procedure for decent communicate death to relative. Mortuary has system to categorize dead bodies before preservation. So all those things. Let me not go into details because if Kaigumba specifically mortuary assess tawhansi haitaragadi, we will have a separate session. Now let's go to the area of concern C, that is RMNCHA and National Health Programs. National Health Programs is for primary health centers, for PHCs and subcenters. RMNCHA is for all. So RMNCHA is such an important topic. The subcenters which are being called as Health and Wellness Center and Ayushman Arogya Mandir was just set up in the beginning just to deal with RMNCHA problem. Then NCD came up, they turned it into HWC. After that, HWC the atopa package hapchalakpai wani, but RMNCHA sidagi nasagi subcenters mayam sisu haukibaneba just to deal with RMNCHA. So RMNCHA deals with antenatal care, intranatal care, postnatal care, newborn and child health, family planning and abortion, and at the end, adolescent health. Antenatal, intranatal, postnatal, newborn and child health, family planning and abortion, adolescent health. 17, that is antenatal care. That is a procedure, established procedure. That means we need an SOP for this. We need a separate, like one line in the SOP of RMNCHA for registration and follow-up of the pregnant OPD. This antenatal care is included in OPD and maternity OTG checklist. Established procedure for registration and follow-up of the pregnant woman. Established procedure for history taking, physical examination, counseling of each antenatal woman visiting the facility. Facility ensures availability of diagnostics and drugs during antenatal care of the pregnant woman. As we all know, pregnant women da akhoi paisa amata charge taude, food phauba lem na pi moigi keno kai PMSMA tauda food free da pi moina delivery tauda institutional delivery tauta rakadi moida 700 rupees p asha da 600 rupees p as per JSY JSSK gi moi free diet lay ambulance ki drop pick up and drop ki service lay drugs diagnostics lay many things akoigi entitlements mayam ama miron be the p ko so okay, so this is the antenatal checkup. Antenatal checkup ki IEC niko. As we all know, for the level of subcenters, this is very, very important. Ki for minimum of 4 antenatal checkups are mandatory by for a pregnant mother. First visit nakarang kantoba, second visit nakarang kantoba, PMSMA nakarang kantoba. What are the investigations investigations that needs to be done by a pregnant mother at the subcenter level? Karang kanda refer to about what are the high risk pregnancies, what are the danger signs in pregnancy, adugumba mayam do loinama during the time of antenatal checkup. Akoina loinama note hodoini PMSMA tha khuding tawdoini. So these are that is the IC material on antenatal care. Next is a high-risk pregnancy. Established procedure for identification of high-risk pregnancies. High-risk pregnancies say, as per a gynecologist, mayamama lerambe, but NQAS ki oina khara mana means of verification. The P1A, if those are identified at the level of primary health centers and sub-centers, that is good enough. Because high-risk pregnancies, akoina kenoda PHC the sum chatlakanda hangba matamda noi PMSMA tawbra tawe high risk pregnancy cam detect tawe amta yawdeda na hyper am yaweba. That is because staff is not aware of what are high risk pregnancies. High risk pregnancies can be as simple as, for the level of subcenters also, for CHOs also, high risk pregnancies can be as simple as short stature, as simple as atopa clinical condition amata natabida, as simple as grand multipara, as simple as teenage pregnancies, as simple as elderly primary, as simple as magi previous LSCS. Adugumba mayamam dugi manungda kharadi soidang yaranganeva. But from the reports, from the records, we can see PMSMA done, no high risk pregnancies detected in a yamla air. Aduduna, that means masagi high risk pregnancy se karamba no habagi koigi kitang awareness kitang what pa subcenter gi level da PHC gi level da uba yaweba ko aduduna NQAS ki checklist gi matung in all those simple ones can be identified. Above that, anemia or hypothyroidism or gestational diabetes or adugumba mayam ama kano dudi laizagredana ko but adugumba dudi ko na test to hodi hai taraga so ngasagi maternal factors mayam dudi that can be identified as high risk pregnancies that can be kept in registers, they can be kept in follow up in case of primary health centers and sub centers. There is an established procedure for identification and management of moderate and severe anemia that is found in OPD and maternity ward checklist. ANC ki counseling pregnant women ki ANC ki counseling gestational age magi fundal height check tauba khopa dugumba mayam mother and child protection card E17 OPD ki checklist ta we see first ki visit adum mother and child protection card piba ANC registered women ki records mayam ma maintain tauba ANC checkup is done as by a qualified personnel at ANC clinic. Pregnancy is confirmed by performing a urine test. Sub-center ki level da, please remember, sub-center ki level da, anybody who comes to your center and says, I am pregnant, you say, okay, but then we will still do a urinary pregnancy test. That is equally true for primary health centers also. Kaigumba CHC go district hospital gadi primary health center dagi refer taragadi, that is okay, it's fine. Otherwise, sub-center ki level da I pregnant or I test over pregnant or I taragadi, don't take that as a positive in a lobby. You have to always make sure you have to confirm it at your center with your kit. Last menstrual period is recorded and expected date of delivery is calculated. CHO singi LMP dagi EDD hotpa I think most of loina khangamani ko first day of last menstrual period to the 9 months and 9 calendar months and 7 days at Tauraga Tarak Papoto Okoina EDD Niena High assessment of clinical conditions of pregnant women fetus of all ANC checkup. This includes fundal height yengba khotpa du mamayamdo yaure fundal height in anywhere ANC checkup tawbham amada fundal height onbagi IEC material ama compulsory oina thepi gadawni ko. There is a specific IEC on measurement of fundal height. This is not about the clinical technical oina fundal height yengbadugi IEC khaktang natana. There are certain preliminaries that we need to follow, like standing on the right side, making the patient lie supine without their knees flexed, something adugumba preliminaries khara malay to rotate the baby in case of primary health centers and sub centers key level. There are certain preliminaries that we should follow before a fundal examination. So that needs to be pasted on the wall at any ANC examination area. Weight, blood pressure measurement are done, pellar edema, icterus. At the level of subcenter, I would like to mention anemia ga asagi urine ga se. 4 times ANC checkup tawgadawni haise. Sida there are 2 tests which you need to do on every visit, and that is your hemoglobin and urine sugar and urine protein. Sigi ani sidi amuktang tawgraga yade. It has to be done on every visit. Every visit the hemoglobin ga urine sugar and protein jese tawgadaba. Abdominal palpation for fetal growth, fetal lie, auscultation. Sigi mayam se what they want is they want all of this to be reflected on your prescription paper of the ANC mother. Identification and management of hypertensive disorders. Hypertensive disorders ki magi screening kamainta way kholi adugumba mayamdo loina yaurani syphilis reactive oitaragadi kaidoba. All those things are here. Technical history, taking physical examination and counseling for each antenatal visits. I'll not go. Let's not go this in details because these are just technical or clinical or pura so let's not discuss clinical part here. Diagnostic tests under ANC checkup are prescribed by the ANC clinic. Oral glucose tolerance test. Oral glucose tolerance test say sub-center level the glucose powder 75 grams on nanaba weighing machine thambiyu ko aduga you have to make it you have to know how to do OGTT at the level of subcenters. Can say 75 gram glucose say ml kaya the thitpa minute kya gi manung da thakpa pung kya gi manung da test tauba kaya taram taragadi akoina adudo diabetes gestational diabetes suspect tauba fasting need oidabra all those things. It's a staff interview questions. 75 grams in 300-400 ml of water to drink in within 5 minutes, and test over after 2 hours. Fasting is not necessary. Aduga, if it is more than 140, then we can suspect at the level of subcenters, we can suspect for a gestational diabetes mellitus. We can have a telemedicine, or we can have, we can refer to it, or we can refer it to subcenter. High risk pregnancy women, line listing for women with moderate and severe anemia. At the level of subcenters also, I would like to point out one thing. You would need to have an anemia register where any patient whose hemoglobin is 10 or 10 gi makha oitaragadi, you need to have it registered in your anemia register. You need to give them therapeutic dose of iron, that is twice a day. Aduga moise every month khudingi kaurakan the hemoglobin check tauba. Aduga number of patients with anemia treated and harakanda thagi angse count tawdoineba. How many people treated for anemia in this particular month? Adugido register amanoina semaga thamdoineba. So please remember anemia not only for pregnant women, it can be for adolescents, it can be for women. Magi can say kaigumba magi anemia se koina sum akoigi facility the iron gi tablet se chahalaga treatment tau gitaragadi, it is a good indicator for you. It is there in your outcome indicators also. Noina anemia se shimi se hana akoi the lak matam da 8 lerambani, next month 9 lere, next month 10 lere, next month 11 lere. Anemia treated at subcenter Pearson 1, like that. Nutritional counseling, all this si yankana changaroi si breastfeeding keke, it's akoi adum tauraga laiba put ngaktani at the level of all facilities. Now, intranatal care, the labor room and labor room and OT da kai yawi see it as a standard procedure. I'm going to define the management of second stage of labor, active management of third stage of labor, newborn, routine care of newborn, and assisted and C-section deliveries ki. Number 1, the second stage of labor. Number 2, the active management of third stage of labor. Ahum subada routine care of newborn. Number 4, the assisted and C-section ki deliveries. I just want to show you. Yeah, it's minor. Not this one. I think I have not put. There is a certain IEC material. I'll be sharing it in group. What needs to be done. Oh, see, this is the active management of third stage of labor. Aduga makhan mayam ama akoina IEC material all PDF you can print it large akoigi print tawba yaba IEC material mayam ama I share tawjarake ko. So akoina huziki sigi intranatal care se the second stage of labor kamain tawe, active management of third stage of labor kamain tawe. These are just akoigi kanoneba, just akoigi IEC material though adu thetaragadi, it is self-explanatory that we implement that in our facility. Now, protocols for, am I audible? Sunan tabra aigi khonja. Am I audible?
Tai.
Okay. Okay. I need to charge my headphone. So, labor room and OT, the facility adheres to standard protocols of identification and management of preeclampsia and eclampsia. That is all this needs to be displayed in the labor room, not in the OT, in the labor room. The facility staff adheres to standard protocols of identification and management of PPH.
sina eclampsia and preeclampsia si jisna intranatal care ki matang dani eclampsia ga preeclampsia ga ki management of PPH, management of HIV in pregnant women and the newborn, and preterm delivery. Sigi IC materials mayamama laini ko IC material mayamama we will be sharing it, and then you can just paste it on the wall of your labor room or OT gisu just outside the manungi OT ki manung the natabida outside the OT clean zone the adum thiet pe aida. The facility has established procedure for intranatal care, infection in pregnant women, established protocol for newborn resuscitation, support to pregnant women means birth companion of her choice. When a labor room the birth companion allowed to vodo adugi potuma to bio habani. Six cleans are clean hands, clean surface, clean blade, clean coat tie, clean towel, clean cloth to wrap the mother. Sigi mayam se this as staff interview sisters into the assessor na hangakadoini ko. Allow spontaneous delivery of the head by flexing the. This is also staff interview. These are all staff interview. They will ask how baby is delivered. So this is the safe birth checklist just on admission, before and during the birth, soon after birth, before discharge. Sige mayam je koina loina main doini ko. Mayam je koina loina main doini. These are safe birth checklist. She main badanatana akoina we will be maintaining the partograph also. Partograph se every delivery ki partograph moina soidana hangakani partograph se maintain tawraganda every patient ki delivery tawgibagi file do da maintain tawbiyoko. Sigisana L3 facility ki maternity services ki magi admission form dune. So mind tawdana admission form delivery form ka kemyam laiko. You can share it if needed. Use of uterotonic drugs, control contraction tawbra. Simam je staff interview ki part naktani. Staff interview da hangani record review sina kaida hangani delivery registered or labor room register. Labor room registered and make sure all procedures are timed. Pung asukta asipi giba pung asukta asupi giba na admaina time tawbiyo. Delayed cord clamping tawbagi mark phangi. Breastfeeding soon after birth tawbagi mark phangi. Vitamin K kapagi mark phangi. These are some things that we have been doing when a heck angang pokpakanda when a tawraga lakpa ngaktani. So these are some things that which we should not be missing the marks. Active management of third stage of labor, kangaroo mother care in front of SNCU, breastfeeding corner, the breastfeeding ki advice or labor room or maternity ward, breastfeeding ki advice. Facility has established procedure for intranatal care ki number 4 part the aware of indication for referring patient to surgical interventions. These are all established procedure ngatani. These are all will be found in your SOP. Record BP in every case of proteinuria. Identify sigi mayam sigi paaba machange ko staff sing sida parakanda session hangakpa matamda question answer khumba ngamdana bagi wani, not much about implementation. So these are the IC materials on preeclampsia, eclampsia, vaginal bleeding, antepartum hemorrhage. Eclampsia toolkit ana sumaina thambase. This is a very good practice. Sigi manungda magnesium sulfate injection adu keke mayamdo loina hapaga thamdoini, including gloves keke mayamzo loina facility procedures. Intranatal care, the uterine tone identifies PPH, manages PPH na PPH ki IC materials like this can be followed, and this is the PPH toolkit. Intranatal, the let's not go into details. These are some things which we can ask in the staff, and if we want to see the records, we will see the delivery record or labor room record. neonatal resuscitation, breastfeeding, many things, pre-warmed towel, delayed cord clamping, initiate breastfeeding soon after birth, vitamin K, all those things. Then postnatal care. Postnatal care is condition of mother and baby providing adequate postpartum care, danger signs, postpartum family planning, exclusive breastfeeding. Counseling on one is danger signs, two is postpartum family planning, third is exclusive breastfeeding. Adheres to protocol of ensuring care of newborns with small size at birth. So, postpartum care, assessment of condition of mother and baby. Number two, the counseling protocol for ensuring with small size at birth, stabilization, treatment, and referral of postnatal complications, newborn in a safe environment, follow up, discharge and follow up of mother and newborn. Discharge and follow up of mother and newborn say HPNC tauba matamda kanona akoigi CHO singna ANM singna HPNC chatpado 3, 7, 14, 21, 28, 42. Sina angang yung ko baby, but postnatal gida 3, 7, 14, then 42. Postnatal. Postnatal care. Postnatal care का HBNC visit का नहीं को for sub-centers for CHOs. These all IC materials we will share, and it's a good practice to paste it on maternity wards and all the other relevant wards. Now, about care of newborn infant and child as per guidelines, pediatric OPD, SNCU, pediatric ward, immunization, management of newborns having emergency signs, low birth weight baby, neonatal asphyxia, neonatal sepsis, child with jaundice, child presenting with fever, cough, and breathlessness, child with severe acute malnutrition, child presenting diarrhea, optimal breastfeeding practices. All this are supposed to have services at the district hospital. Sigi service mayam se pediatrician laiba district hospital the equina service se PB gadawni have available. And if given, the staffs are aware of the protocols, the staff are trained to have to support the doctor, the pediatrician in managing all these cases. If cases later taragadi, we shall be prepared to take all those cases in case it comes in the in future. Immunization ki matang da, this is a pure case of ANM zingini ko. Sub-center ki level da zu ANM mein humne handle tawi immunization se about vaccine while monitoring, outer circle, inner square, outer circle, inner square, outer circle, inner square. Sigi say only when this is lighter and this is darker, only then this can be used. In this condition, when this is same color or this is darker, inner square darker than the outer circle, inner square same color as the darker circle cannot be used. This is for subcenters, ANM subcenters. Staff is aware how freeze damage for T series vaccines. T series se DPT, DT, Shungba, TT mayam se freeze damage over. Discarded vaccines are kept separately, have not kept in direct contact of the eyes. DPT, DT, hepatitis, and DT vials are not kept in direct contact of the vials. They can be kept AD syringes are available. Staff knows how to use the correct AD syringe. check AD syringes are not used. All this are part of immunization. On top of this, I would like to just highlight a little bit in your immunization room. May it be for a district hospital, may it be for PHC, may it be for UPHCs, whatever immunization tawba mafamda, please make sure in an immunization room your national immunization schedule is displayed, your VVM is displayed, your open vial policy is displayed, your 4 key messages is displayed. And number 5 is you have a waiting area for patients to sit for 30 minutes after immunization. National immunization schedule, vaccine vial monitoring, OVP, aduga nasaigi sigi which where to keep vaccines. Vaccine gi kanoda mathakta kai thamgani, nakanda kai thamgani habado adugi IC material amaga. At least these aduga in case of subcenters, your microplan due lists should be displayed. And January, February, March, April tarakanda so at least these are supposed to be pasted on the immunization room of your respective facilities. So this is the Siri Mayamadum Ubiramani. It's just a refresher of how we keep our vaccines. Sise ANM na adum khangbani, but then in case PHC the cold chain labor mafam the ILR labor mafam the SSR lataragadi, they will ask where do you keep what makha the kai makha the kai thami kai kai mayam se ha kani. So this needs to be aware of changi. Family planning counseling services. Family planning for a level of subcenters. Please remember there are 2 kinds of family planning methods. Temporary, permanent, haibigano. Please call that as spacing and limiting methods. Spacing haitaragadi like condom or OCPs or antara, chaya, all those things. And limiting haitaragadi tubectomy, non-scalpel vasectomy, tubectomy, surgery tarakanda total kano tawgibaze sterilize tawgibaze adu oidoiniko. So spacing methods ki group ama, limiting methods ki group ama. Services for abortion as per guidelines, services for first trimester abortion as per guidelines, provide services for second trimester as per guidelines. In case of CHC, as I have said earlier, in case of CHC, moiki CHC OT se. CHC OT, if not functional, that's okay, because Sigi first trimester abortion, second trimester abortion gi surgery se kaigumba tawrak taragadi adugi potugi yam laiba checklist ama NHSRC na customize tawraga pirakani aduduna we will make sure at least our abortions, our limiting methods of family planning are implemented at our facility. Just to have some details, let's say spacing methods ki the pills should only be given to those who meet the medical eligibility criteria. Clients should be given full information about the risks, advantages, and possible side effects of OCPs prescribed to her. In case of subcenters, the family planning gi ani lai braided approach haiba amane aduga gather approach haiba amane. Braided approach like benefits, risks, alternative, inquiry, documentation, inquiry, and all the greed, ask, tell, you have to be
Yeah.
How?
Voice to kitang low oy bumale.
Tadabra. Am I
Tapari.
audible, everyone? Can I have someone from Churchanpur? Am I audible? If not, then I'll be connecting another microphone.
Anyone from Senapati and Chuchanpur?
Yes, we can hear you, sir.
Okay.
Okay, carry on, Cesar.
All right. One second. So about family planning, specific spacing method, limiting method later. Sigi Kenosida, CHOs need to know what are gather approach and braided approach of family planning. Counseling to the gather approach havunga, braided approach havunga. Season agani, this is the eyes noiki facility the like family planning methods mayam duni. This is the easy pill which needs to be, this is the emergency contraceptive pill which should be consumed before within 72 hours of intercourse. Chaya is your non-hormonal family planning method. It is called as Sencromen and it contains ormeloxifene. Mala N sina noigi 28 days 28 tablets yauba kenoduni 28 tablets yauba OCP oral contraceptive pill duni antara injections which is given every 3 months. Antara injections in a every 3 months piba aduga it contains it is injectable aduga chaya ga antara ga ani je pige haitaraga you need a authorization from the medical officer that they can take antara injection checkup tawba machangi condoms later then property 375 which validity of 5 years chatpado then property 380 that runs for 10 years. Sige mayam sida koina any family planning method for the level of sub centers and CHOs, any family planning method ama season hange or moida pige haiba matamda you need to first check their urinary pregnancy test ama hana tawraga pregnancy oiramdragadi negative taragadi only then you will prescribe all this. Then facility provides promotive hours services, promotive hours, preventive hours in adolescent ki services, then promotive, preventive, curative, and provides referral services for our services. So the ying is for the case of adolescents. Provision for antenatal checkup for pregnant as the adolescents, contraceptive pills ki matang the counseling, contraceptive display of IEC material. Simyam se kaida loina akoina cover to ge haiba matamda we have a register like this for adolescent friendly register where we write the date, UID number ama pire magi walk-in la referred la age ama pire maming matha ire sex marital status presenting complaint aduga magi sigi clinical services se menstrual problem oira skin problem oira ANC oira IFA tablet novel oira contraceptive kira sugumba mayam se we just write it down. Services provided to the client, counseling about sigi mayam se counseling se loin to biba machange aduga kona magi kenose counseling to matamda we tend to miss out counseling on deworming to biba need way. Please remember whenever we deal with an adolescent patient we always promote deworming substance abuse, sexual problems, all those things, depression, mental mental health problems. So this is the kind of adolescent friendly register maintain. All those which is being asked here are covered in that register. So it's 12:49 now. The part for clinical services is done. Infection control, shall we take a break for lunch? Can I have someone from Chochanpur or anyone? If 10 minutes should we continue with the session or should we have lunch break for 45 minutes?
Let's break. Cecile, let's take a break.
Okay. All right, let's take a lunch break then, and we will come back by 12:40 then. Okay.
It's 12 or 1?
Oh, sorry, 1:40. Yeah. 1:40.
Okay, thank you.
Thank you. So antibiotic policy framed at the facility level or customize the already implemented RIMS and implement. Then now let's go to F2. F2 talks about the first standard precaution, that is hand hygiene. That talks about the first thing that they talk about is the hand hygiene area or hand hygiene facilities are provided everywhere at the point of use, as in the OPD, in the labor room, in the OT, in the lab, everywhere at the point of use, hand washing facilities are provided. Staff is trained and adheres to the hand washing practices. Facility ensures standard practices and materials for antisepsis. Aduna akoina hand washing point amada hand wash ki basin do, like the depth should be maintained. It should be elbow taps. The hand sanitizer should be there, but hand wash should be there. Nowadays we recommend the liquid hand wash types. Then wash basin should be available at every point of use. So availability of wash basin, elbow operated tap at the point of use, availability of running water, uninterrupted supply of soap or liquid antiseptic, availability of alcohol-based hand rub, and display of IEC. These are the ones hand hygiene so hand washing facilities are provided at every point of use. Basins are provided, running water is provided, soap is provided, IEC material. In any facility, may it be sub-center, PHC or district hospital, if there is a hand washing point, even though it is for the hospital staff or even though it is for the public, please display IEC on hand wash. Then F2.2, that is about adherence to 6 steps of hand washing, when to wash hands, that is moments of hand washing, and records of hand washing training. We should have a training register, and every quarterly we should be doing Kayakal training, and in that we will include this records of hand washing training. Let's see, these are the 6 steps of hand washing. This is actually the 5 steps of hand washing. I'll tell you something. When you display IC material on hand wash, one assessor may say something, another assessor may say something. One may say this is 6 steps of hand washing, one may say this is 5 steps of hand washing. WHO says something, but then as per our experience, we would like to share something called as Suman K. I think everybody must have heard about Suman K. Suman K is the Hindi abbreviation of what 6 steps of hand washing means. And this should be nowadays facilities have started displaying IEC as per Suman K. Suman K, S means Seedha Seedha, that is palm to palm. Okay, why I'm saying Seedha Seedha, Ulta Ulta, twice is because one is for left, one is for right. Seedha is palm to palm. This is Ulta. Ulta is from the back of the palm, the right side of the palm on the back of the left hand, or the left side of the palm to the right back of the right hand, that is Ulta. So this is Ulta. Then M is called as Muthi. Muthi is this thing is called Muthi, that is your fist. It should be done left and then right. That's why I'm saying Muthi twice. Then A is called as Angutha. Angutha is your thumb. Angutha is your thumb. Then N is your nakhun. Nakhun are your nails. So these are your nakhun. This is nails. This is your thumb. And in the last, this is called kalai. This is your wrist. So if you follow, whenever an assessor asks you, tell me the 6 steps of hand washing, if you say the 6 steps of Suman hand washing, no one will deny. So better stick to Suman K, which is in India at least, which is followed everywhere. Seedha Seedha, Ulta Ulta, Muthi Muthi, Angutha Angutha, Nakhun Nakhun, and then Kalai. Muthi is left muthi and then right muthi. Angutha is left thumb and right thumb. Nakhun is right thumb and left thumb. So these are the 6 steps of hand washing. So adherence to 6 steps of hand washing, we should tell each and every category of staffs, may it be multi-purpose worker, male health worker, grade 4, kitchen staffs, everybody needs to learn Suman, and the people who are doing procedure needs to learn Suman K, because while doing any procedure, before any procedure, you need to wash your wrist also. Otherwise, in general, you don't need to wash your wrist. So 6 steps of hand washing, adherence to 6 steps of hand washing. Then when to wash hands is your 5 moments of hand hygiene. 5 moments of hand hygiene. I'll tell you one thing to the, especially to the CHOs. I think most of the people, most of the staff from district hospital or higher level facilities must be knowing. Please remember 2 before and 3 after. 2 before is before patient contact and before exposure. 3 after is after contact, after exposure, and after leaving. All right. So 5 moments of hand washing. Always remember 5 is 2 before and 3 after. 2 before is before patient contact. 1 is before the exposure to aseptic task or before any kinds of exposure. 3 is before, after the contact of the patient, after exposure to body fluids, or lastly, the third one after is after leaving the patient surroundings or after contact with the patient surrounding. So this is the 5 moments of hand washing, and this is the 6 steps of hand washing. This is very, very important, which will be asked in your assessments. Compulsory, 100% this will be asked. Number 3 in your hand hygiene is availability of aseptic solution, and adequate supply of antiseptic. Lastly, proper cleaning of surgical site with antiseptic, which is hand hygiene. So third one is about personal protection or personal protective equipment. Personal protective equipment ta ani yawi. One is adequate personal protective equipment laiba ama shetpa ama. Ani subada adheres to the personal protective equipment or practices. For example, if anybody is going for procedure ama tawdore hai taragadi aduda shetpa personal protective equipment tongana ama. Kaigumba blood spill management tawdore hai kanda aduda sizinaba personal protective equipment tongan ba ama. Then mercury gina tongan ba ama, then OT gina tongan ba ama. It is all different. Aduna akoigi personal protective practices at relevant areas. So quite ihan han bada for personal protective equipment, what we have to have is caps, gowns, masks, protective eyewear, sterile gloves. Sigi sterile gloves hai. Please remember, nurses, they need to know how to wear sterile gloves. They need to know how to wear loose gloves. Compulsory hangkani packet hangdu okanda. Please train them. The hospital quality committee, please train all the nurses how to wear sterile gloves. Everybody must be knowing how to wear sterile gloves, but just magi theory magi guideline ama lairiba mapanda touch tawba yadaba manungda touch tawgadaba. That particular protocol needs to be followed when assessment happens or when a competency assessment is being done. So availability of personal protective equipment na part ama oire, availability of sterile gloves na part ama oire, availability of elbow length gloves for obstetric procedures. Elbow length gloves khara thamba dakar oi haire. Availability of heavy duty gloves and gumboots for housekeeping staffs. It is not only about the healthcare workers, it is also about the housekeeping staffs. We need to have gumboots, we need to have heavy duty gloves. Why? Taiba matamda mercury spill manage tauba matamda. At those times, we need all those gumboots, heavy duty gloves, all those things. Facility ensures adequate and regular supply of PPE. Aduna PPE ki supply yenge hakani in that upu manungduda gloves mayam ama display tauba mathau tai adagi mask, headgear, foot cover adugumba mayam se loinama koina utpa ama darkar tai. So F3 talks about personal protective equipment. Donning and doffing ki part ama hakani. I will not go into details because sigi pot se quality team na facility ki staff singda kitang train taubiyo ko. Then another one about personal protective equipment is no reuse of any kind of disposable gloves, caps, or gowns. Compliance to correct method of wearing and removing PPE. Entry to the critical areas only after wearing shoe covers, masks, and caps. For sub-centers ki, as I have mentioned earlier, facility ki manungda, please try to wear facility ki oiba footwear oina tungna na batawiyo ko. It is best. Then policy for judicious use of PPE and especially sterile gloves. Sugumba policy mo budya ko na SOP to the half kaniko. Then the second standard kanogi infection control gi third part, which is your personal protective equipment. Then comes some technical portions, which is your instrument processing, instrument sterilization, environmental disinfection, and biomedical waste management. Nasaigi standard precautions, aham bagi hand hygiene, very easy. Second, personal protective equipment also very easy. The tricky part is the instruments processing or instrument sterilization and environmental disinfection. This is kind of tricky. So mayamsi ki say once and for all confusion like how we process the instruments. I will be sharing a video also later. We can see that as well. But please listen to it very carefully. Once and for all confusion like there's lots of confusion in there. So let's just skip all this. Let's all skip the theory part and let's just go into the practical part. First thing, whenever any procedure is being done in the labor room, maternity, OT, minor OT, anywhere, So the first one is in the instrument processing, the first one is decontamination and cleaning of instruments. Decontamination is being done so that it is safe for the person who is handling those instruments, who will be washing those instruments. So please remember always, please don't forget, whenever a procedure happened, all the instruments are being taken out, all the contaminated instruments are taken out, and we do not wash it. We first dip it in the 0.5% hypochlorite solution and we decontaminate it. The first step of instrument sterilization or the first step of instrument processing is decontamination, and it is not washing. Please remember, at the level of sub-centers, when you perform a VIA, when you perform a dressing, your contaminated instruments should be decontaminated first and not washed. Washing should come after decontamination of instruments. So disinfection of procedure surfaces, wiping with 0.5% chlorine solution, that is fine. Disinfection of instruments after use, this is called as decontamination. Which is done with 0.5% chlorine solution, dipping it or wiping it with 0.5% solution or 70% alcohol as applicable to those instruments which gets corroded with hypochlorite solution. The third one is handling of soiled linen, staff training for preparation of disinfectant. The facility ensures adequate regular supply of disinfectant, adequate contact time of disinfection. These are just theory part. Let's just go to the practical part. So please see here, whenever any instrument is used in the maternity OT or labor room, minor OT, or anywhere it gets anywhere if it is contaminated, first thing what we have to do is decontamination. All the instruments, put it in a jar. All the instruments are put it in the jar. Put 0.5% hypochlorite solution and keep it for 10 minutes. Don't keep it more than 10 minutes because it will corrode the instruments. Don't keep the scissors and all because that will corrode. Just put all the instruments in the tub for 10 minutes, dipped in 0.5% hypochlorite solution. That is called decontamination. Please remember this. This is very important. Next, we thoroughly wash and rinse the instrument and we then dry it. After drying the instruments, we can follow two procedures. One is the preferred method, another one is the acceptable method. Preferred method is sterilization, whereas acceptable method is high-level disinfection. The difference between sterilization and disinfection is that sterilization takes care of the spores and protein particles, whereas high-level disinfection do not take care of the spores. However, in cases of primary health centers or sub-health centers especially, if you are not dealing with if you are not dealing with procedures which do not require that much of invasive procedures, high level disinfection in your level of facility is just fine. However, if you have an autoclave, if you can sterilize, that is the best, that is the acceptable method. If you don't have autoclave, don't think that since you do not have autoclave, you cannot go for NQAS. Don't think like that. In sub-center level, we do not have that much of invasive procedures. So high-level disinfection or boiling is also just fine. Let's move forward. We first decontaminate the instruments with 0.5% hypochlorite solution, dipped for 10 minutes. Then we wash it, we dry it, and then let's go for the preferred method first. The preferred method is autoclaving, which is the thermal, and chemical is with Sidex or glutaraldehyde. So let's see. First, let's take up autoclaving. Autoclaving, the temperature of autoclaving is 121 degrees Celsius in 0 106 kilopascals or 15 to 20 pound pressure, 20 minutes unwrapped, 30 minutes wrapped, as I have said earlier. If any instruments are wrapped with linen, autoclaving should be done for 30 minutes because the linen itself takes 30 minutes for itself to get sterilized. Instruments will get sterilized in just 20 minutes if you put it open, but then if you wrap it with linen, the linen itself takes 30 minutes to sterilize. So when you wrap instruments with linen, you will have to keep it for 30 minutes. Then let's go more on autoclaving. Autoclaving say, first thing what we have to do is I'll just tell you the procedure like from the beginning. First thing is, sorry. First thing is decontamination, as we have said. Second is wash, then dry. Then we put it in the tray, or we put it in wrapped. Linen the wrapped tawre khalasel. Wrapped linen se soina wrapped tawre linen na, and then we keep it inside the drum. Then before we do the autoclave, we put all those things inside the drum. First thing what we have to do is we have to close these vents. Aduna assessor na hangakani, how do you can step by step linen se wrap tawre. Linen wrap tawre ba matungda, you have to put this signal lock in the linen. Signal lock se mayam tabira brahana. I think everybody must be using it for now. But whenever you wrap an instrument, whenever you wrap instruments in linen, you have to tape it with this signal lock. There are two advantages of this signal lock. One is magi wrap tawgrabanina maze sellotape napsan by type ta. Another thing is when autoclave say effective matamda, it will come like this. This magi sumaina leramba fresh the leramba ze si sumaina fresh the leramba sumaina line chingakta ragadi, it means that your autoclave is successful. When the autoclave is complete, sumaina line chingamta ragadi, your autoclave is efficient. 121 degrees Celsius yaugrabani, 15 pound pressure yaugrabani, 30 minutes thammabani haine basigi line chingaise. So these are some of the examples of effective autoclave being done. Sigi autoclave ki signal lock se linen nama dangna yomaba matungda, if you tape it with this, write the date here. Date amas daisa ishan bioba, so that you will know when was this set of instruments autoclave that khang nanaba daisa ishan bioba. What you have to do is then sigi pot se manung da hapchal lebo ko. Drum ki manung da hapchalle, sigi vent se sumaina khumjalle, and then that signal lock, sigi signal lock se, this signal lock, please put 2 copies, 2 strips here also, and write the date. Ani shida is the nap to ishana kaigino haikanda, one will go to the register. Autoclave tauraba matungda register da nap khidoine basigi asagi signal lock se effective oire haiba pot se, to have the proof in the register that this set was autoclaved. Another one se sidais da adum napaga thamoba, so that it is an indicator that it was autoclaved. So first thing, decontamination taure, wash taure, dry taure, instrument mayam se you wrap it with linen, and then tape it with the signal lock. You keep it inside the drum, you close the vent, and then you start the process of autoclave. Autoclave se kamaina tawgadagi haitaragadi, first you open the autoclave. Then the heating filamentum yarongane, the heating filamentum yarongane. What you have to do is first open the autoclave and fill water till the filament is submerged with water. Till the filament is submerged with water, and then you put the stand. My stand, stand to hapo ba says. Then you put the drum. The drum should have 2 signal locks pasted. The vents should be closed, that is ready for autoclaving. Then you close the autoclave. Autoclave se open tawdoi se, it should be anti-clockwise. And you close it clockwise. You close the autoclave. Then nangi sigi pressure knob kai mayam se loina tighten tawbigrobo. Then you turn on the autoclave. After you turn on the autoclave, nasai 30 minutes haida count you should not count 30 minutes after turning on the autoclave. You see this knob. It's like this, and there's a part which is green. When it comes green, that means the temperature has reached 121 degrees. It has reached 15-pound pressure. The moment this knob reached this green area, you start counting your 30 minutes. 30 minutes count out biro, or there are certain autoclaving machines where this thing is available. Magi alarm system zu yawe. Then akhoi kanoda sidai autoclaving se 30 minutes tawraba matungda we will turn off the autoclave machine. We will let it cool for some time, and then you loosen this all magi knobs mayam mga side lection kiba mayam do. You open it so that all the steam, all the pressure, everything will be released. Then you open all this, and then you open it anti-clockwise. You can now take out the drum. After you take out the drum, now what you have to do is immediately you have to again close this vents. Autoclave tauringai manungda drum gi vents mayam do open dauba. Autoclave loiraba matungda adugi vent to satlauna close dauba. Once it is closed, then you have a drum which is autoclaved, which have instrument sets inside. You have two sets of signal lock pasted here. This is closed. This particular drum can be, if kept without opening, you can keep this drum. It is valid for 7 days. If you have opened this drum, this will be valid for 72 hours. And the set if opened, it will go only 24 hours. So there are 3 kinds. Drum, if not opened, can be kept for 7 days. If it is opened, if you have opened and you have 3 sets of linen here, you can open it, and then you have to use all these 3 sets of instruments within 72 hours. If this particular linen set, if you have opened it, let's for example, if you have opened this, then you can use it. You have to use it within 24 hours. So that is how autoclaving is done. I think I have made myself clear. If there is any problem, we can discuss later also. So now coming back to preferred method of sterilization, one is the autoclave, which we just discussed. The another one is chemical method. Chemical method is to dip with Sidex. The chemical that we use is Sidex. which is 2% glutaraldehyde. But what I want to focus here is chemical, the same neighbor. The same chemical is used for sterilization also. The same chemical is used for high level disinfection also. But the problem, the main difference is, if you want to sterilize certain instruments with Sidex, you have to keep it dipped for 10 hours. If you want disinfection, 20 minutes is just fine. Right. Sidex na, you can use Sidex to either sterilize an instrument also, you can use it for high level disinfection also. The difference is you have to keep it 10 hours for sterilization and you have to keep it 20 minutes for disinfection. That's the only difference. And then after your sterilization or disinfection, whatever is being done, after that you just have to dip it in sterile water so that the glutaraldehyde is washed away. And then you can keep it. That is your sterile instrument. You can call it sterile, you can call it high level disinfection, as per how much time did you submerge that. Now next is about thermal high level disinfection. Okay, this is especially for subcenters where autoclave is not available. If in your center, autoclave is not available, you must be having a boiler. What you have to do here is you just have to put the instruments here. That decontamination has to be done first. After decontamination, you will have to wash it, you will have to dry it, and then only you will have to submerge it. And you have to submerge it completely in water, not like one arm of scissor is like this, one arm of scissor is like this and like this. It cannot come out of the water. Everything should be submerged under water. The thing is, when the assessor asks you in a boiler, how much time do you keep for an instrument to make it high level disinfection? That is, everybody knows that's 20 minutes. But the catch is 20 minutes is after boiling, okay? Not after turning on the switch. When you put the 3-pin socket and then when you turn it on, you don't time it. You close the lid. You can never open the lid if once it is closed. Close the lid, wait for it to boil. In the peripheral areas, in subcenters, power, the light also may have, that much of voltage. It may take time to boil. Let it boil. After boiling, keep for 20 minutes, and that is your high level disinfection. You cannot just turn on the boiler after boiling, after just turning on for 20 minutes. I think I have, okay. Okay, right here. As we can see, the exact guideline is written here. Here. Lid on 20 minutes after boiling. Lids on means should be closed, okay? Articles should be completely immersed in water. Used for gloves, instruments, and glass syringes. This is high level disinfection to be implemented in the subcenters if your autoclave is not available. This is not acceptable in any of the primary health centers, CHCs, or district hospitals. I would like to add one more thing for subcenters. You cannot sterilize or you cannot sterilize cotton with high level disinfection, as you cannot boil cotton swabs. If you do not have autoclave and if you are using high level disinfection as your sterilization method or high level disinfection method, you please consult your linked PICs for the supply of sterile cotton. Otherwise, assessor will ask you, if you don't have autoclave, where do you get the sterile cotton from? At that time, you should have a linkage with your primary health center to get the sterile cotton at your place. All right. So I guess instrument sterilization is done. To have a brief summary, it should be decontamination, 0.5% chlorine solution for 10 minutes, not more than 10 minutes because it will corrode, then wash it, then dry it, then you can go for preferred method, which is sterilization that can be done with chemical or thermal, that is autoclave, or you can go for high level disinfection that also can be thermal, which is boiling, and it can be chemical with glutaraldehyde. Now, this 0.5% chlorine solution that we use for decontamination of instruments, how do we prepare it is another question. So what we do is we have to prepare 0.5% hypochlorite solution. Whenever anybody asks you how do you prepare 0.5% hypochlorite solution, people gets confused. People used to tell us 100 ml of this, 400 ml of this, 700 ml of this, 1 liter of this. Just I would like to change that perspective. Please don't use the word ml, or please don't use it, especially for the sub-centers or primary health centers. Even district hospitals can implement. Please use parts while preparing hypochlorite solutions. Parts is much easy. You don't need a measurement, a bowl, a measurement jar, or anything. You can use any jar to measure this hypochlorite, or to prepare the hypochlorite solution. So let's see the supply that we get for hypochlorite solution. Many of us will, I understand, many of us will say there is no supply for hypochlorite solution. But then even if we buy it from the market, that we get 5% hypochlorite solution. That 5% hypochlorite solution, we take 1 mug. This can be a dispo cup also if we want to prepare small amount. It can be a big jar. It can be 100 ml, 200 ml, whatever ml it is. That particular jar, the same jar, put this jar here, and then that is your one jar of 5% hypochlorite solution. Then you mix this same jar 9 times, 9 parts of 9 jar of water. Okay, same jar. Now this is 9 jars and this is just 1 jar. That will give you your 0.5% hypochlorite solution. I'll repeat once again. If you want to prepare 0.5% hypochlorite solution from 5% hypochlorite solution, then mix 1 part of hypochlorite solution. 1 part means it can be 1 jar, 1 cup, 1 anything. That same jar or cup, use that to get 9 parts of water. Then put it inside here. 1 part of 5% hypochlorite solution with 9 parts of water. That will give you your 0.5% hypochlorite solution, which you use it to decontaminate the instruments for 10 minutes. If in any case, if you get 4% hypochlorite solution, then it is even easier. 4% hypochlorite solution, you take 1 part of 4% hypochlorite solution mixed with 7 parts of water. 9 and 7. 9 is from 5 to 0.5. 7 is from 4 to 0.5. Right. So this is how we prepare 0.5% hypochlorite solution, which we use to decontaminate the instruments. Now, if we have 1% hypochlorite solution, it is the best. It is most easy to prepare 0.5% hypochlorite solution from 1%, because we just have to put 1 jar of hypochlorite solution, which is 1%, mixed with 1 jar of water. Same, 50-50. Okay. Then you'll just get 0.5% hypochlorite solution in 1 jar. 1 liter of 1% hypochlorite solution with 1 liter of water, you'll just get 0.5% hypochlorite solution. For theoretical purpose, if an assessor is interested in preparing 1% hypochlorite solution, then this is it. 1 part of 5% hypochlorite solution mixed with 4 parts of water. That's a mnemonic, like 5% dagi 1% tanaba semba matamda 4 parts of water changi haveniko. 5% dagi 1% tanaba sembada 5 minus 1 is 4. So 4 parts of water is needed. So this is just theoretical. If an assessor wants to know 1% hypochlorite ka minus CMG hangtaragadi, and especially for sub-health centers, 1% hypochlorite solution is needed for disinfection of glass vials. That is blue bin. This is not needed for primary health center, district hospital, or anywhere, but for sub-center level, 1% hypochlorite is necessary for disinfection of glass vials, that is blue bin. This is just for theoretical purpose. I believe in all the health centers you are using bleaching powder. So let's now learn how to make 1% solution or 0.5% solution from bleaching powder. So this is it. So we take 1 liter of all right. So to make 1% hypochlorite solution, and this is to make 0.5% hypochlorite solution, take the bleaching powder, take 3 teaspoons of bleaching powder and put it in 1 liter of water. 1 liter of water, the 3 teaspoons haptaragadi 0.5% phangi, aduga if 6 kano haptaragadi 6 spoons haptaragadi, we get this 1% of hypochlorite solution. Now, I think that is clear how instrument processing and instrument sterilization is being done. If there is any more questions, then feel free to please comment in the message section, or you can send us the in WhatsApp message also. Moving on to the environmental disinfection, environmental control. So layout for infection prevention, disinfectant materials, environmental cleaning, isolation, barrier settings, and air quality. Air quality is not included in anywhere else. It is for district hospital and CHCs only. Physical layout for infection prevention, disinfectant materials, environmental cleaning, that is F5, that is environmental control. Now, let's see. Layout for infection prevention as we do in OT, or separate wood floor, clean and dirty linen floors, and walls of high-risk areas are cleanable. These are not very technical ones. These can be implemented. Now, this is the in any OT or any places where OT or any, most of the times it's OT, but let's say in labor room also, or any other procedure room, we follow this protective zone, clean zone, sterile zone, and disposal zone. So when we have a setup, we have the protective zone where you have the OT ki reception, sister ki station, staff ki toilet, all those things in the protective zone. And then you enter, you have the clean zone. You have the clean zone where you have the recovery room, anesthesia room, the beds and everything is there in the clean room. And uske baad the sterile zone. Sterile zone is generally the OT. And then you have a small veranda that goes like this. That is the disposal zone. So from OT, you don't go out. You just have to put everything to the disposal zone. And then from that disposal zone, the separate veranda comes out. Separate veranda comes out where you can take out all the dirty linen and all those biomedical waste bins from outside. It doesn't go like this. It will go to the disposal zone and it will come out like this. We will not go into details about this. If any facility is implementing, then we can have a separate session on it, because it's we have to consider IPHs as well as infection control of NQAS while implementing infection control in OT or zoning areas. So layout for infection prevention, just we have to know is about the protective zone, clean zone, sterile zone, and the disposal zone. Disinfectant materials is availability of standard clinical cleaning materials and disinfectants. So spill management, environmental cleaning, spill management, cleaning of patient care areas, mopping and scrubbing, no broom in the patient care area. This is very funny. Once an assessor came and asked the sweeper that do you sweep in the wards or do you sweep in the procedural areas, and then he happily said yes, twice a day, whereas like brooming or this should not be done in the patient care areas. There should be only wiping. Use of 3 bucket systems. External footwears are not allowed in OT or ICU. These are the means of verifications. These are the checkpoints which the environmental cleaning looks for. So this is, I have seen many blood and body fluid spill management, which is wrong, which is not as per guidelines. Many, we have seen many IC materials on which it is written phenyl should be used for blood and body spill management. That is wrong. This is as per the complete Kayakalp guidelines, so please follow this. There are 2 kinds of spills, that is small spill and large spill. Small spill is few drops or less than 10 ml. Large spill is more than 10 ml. For few drops, we use 1% hypochlorite solution, and for large spill, we use 10% hypochlorite solution. Nowhere in this Kayakalp guidelines is written for small spills you have to keep for 5 minutes or 10 minutes or 20 minutes. It just says like keep it for few minutes. That's fine. We use 1% hypochlorite solution for small spills, and then we just keep it for a few minutes, and then for large spills, we use 10% hypochlorite solution. In any case, if you do not have 10% hypochlorite solution, if you have 10% hypochlorite solution, then you have to use 10% hypochlorite solution and keep it for 5 minutes as it is written here. In any case, if you do not have 10% hypochlorite solution, then you can use 1% hypochlorite solution and keep it 30 minutes. Keep it for 30 minutes, as this is Infection and Preventive Control Guidelines 2020. That is written there. So if you have 10% hypochlorite solution, for the assessment point of view, I would request you to keep at least some amount of just 1 liter of 10% hypochlorite solution just to clear blood and body spill management, not to be used in anywhere else, because as per guidelines, blood spills, if it is more than 10 ml, as per guidelines, it should be wiped off with 10% hypochlorite solution. Keep it for 5 minutes, wipe it off. If you can see some stain on the floor, wipe it off again. That is the exact guideline that Kayakalp has given. If you did not have 10% hypochlorite solution, you can use 1% hypochlorite solution, and you should keep it there for 30 minutes as contact time. But please remember, in nowhere it is written that for small spills you have to keep it for 3 or 5 or 10 minutes. It's not written like that. So just few minutes is just fine. Cleanliness protocols on how to use the cleaning, how to mop, all those things are written, is given. There is this 3 bucket system. People usually get confused on what to put on the first bucket, what to put on the second bucket, and what to put on the third bucket. First is water with detergent used in the beginning. Second is rinsed in the second bucket. Third is the disinfectant. Second bucket is for wringing and it does not contain water. Those who are targeting labor room and maternity OT, please remember this water, the water that you use to clean the labor room, should be warm water from geyser. You have to put warm water, you have to put the detergent, mix, and then wipe. That is how it is supposed to be done for Lakshya. Labor room and maternity OT, you need to have geyser for for assessment of Lakshya. Labor room needs to have geyser, maternity OT needs to have geyser. You need to wipe the floor with warm water, which is you get from the geyser. And this is how you mop the floor. Blood spill management. Now isolation, let's not go in details about isolation and air quality. Now let's go to biomedical waste management. Biomedical waste management, one is the segregation, one is collection, third one is transportation, and fourth one is disposal. I would like to just tell you one thing here. Facilities at the level of district hospital, CHCs, SDH, and PHCs, if they are located within 75 km from Imphal or common biomedical waste, treatment facility, this will be CJA and no state pollution control board, number one. Number two, if it is more than 75 kilometers, you need license from State Pollution Control Board for one, deep burial pit and sharp pit. Deep burial pit should be 6 by 6 by 6 at least. Sharp pit should be 1 meter by 1 meter by 1 meter. 6 feet by 6 feet by 6 feet. Probably you can do 10 10 10 also, but then 6 by 6 by 6 is minimum. So facilities at the level of district hospital, CHC, SDH, and PHCs, you have to have linkage with the common biomedical waste treatment facility. Quality assurance unit will be providing the funds for PHCs for now. In the subsequent years, we may try to provide for CHCs and district hospital as well if approved. Then 75 kilometers like the linkage layer. If more than 75 kilometers, one license should be procured from the State Pollution Control Board to have the deep burial pit, duct, and sharp waste pit. Now, for the level of armed subcenters, they should give their wastes to linked PHCs, no matter whether the linked PHC is linked to CJA or not. Linked PHCs, if more than 75 kilometers, will be linked to CJA. If more than 75 kilometers, they will be provided funds for deep burial pits. And the mother PHC is responsible for the waste which is generated from armed sub health centers. Now, let's say this is the latest IEC material or the work instructions on biomedical waste management. The latest guidelines say that instead of writing anatomical waste and soil waste, chemotherapy, human anatomical waste, or all those things in front of a yellow dustbin, they have released a new guideline that says make it pictorial like this. They want all those work instructions to be pictorial, like human anatomical waste, all those things. Like if you are putting a biomedical waste segregation sticker, then please make sure it is protocol for in pictorial format. So let's see, the yellow bin is about human anatomical waste. Center ki level, it will be mostly cotton and dressing materials. Then PHC, if delivery the human anatomical waste or placenta, blood, all those things will come out in here. Red is all about IV fluids ki tubings, IV fluid ki bottles, syringes, all those things will come here. Glass, this is about glass vials, and this is metal sharps. One thing about primary health centers and sub-centers is, for district hospitals, it's fine because they use a lot of injections and a lot of glass vials is being adum puthuebako glass vials mayamama season because they use a lot of injections. But in the case of primary health centers and sub centers, they do not use that many injections. So blue vials and this white vials, don't make it as same size as yellow and red. Make it smaller like this. Metal shops and glass shops, most of the time at the level of primary health centers and sub centers, not that much. So yellow bin achauba ma thambado adumaina blue so achauba ma tham taragadi, it's a huge wastage. Aduna glass vial ki thambam je jumbo macha gumba ma natragana container macha gumba ma adumaina oina thammo. Don't make it as big as the yellow and red. Let yellow and red be big sized, then the blue and the puncture proof container white should be little bit smaller size. Then sigi puncture proof container ki disposal se, what you have to do is you have to keep throwing this away. You cannot segregate this, you cannot when you give an immunization, let suppose from the level of subcenter, when you immunize a patient, syringe to na red the chat needle cutter the hub cutter to the needle to yauraga lehore needle do nang sigi puncture proof container sida adhare, you cannot sigi puncture proof container sida ki khaido khaijin tawba yade ko, it has to be given. Aduna most khwaidagi best option is to have this chewing gum ki boxes kumbada, chewing gum ki boxes kumbado adu kumbada hapa ga thamba, and then adu hapa matungda 2/3 kumba thallakanda adumaina pikiba ko. That's another option. So blue is for glass vials, and puncture proof container white is for your metal sharps like needles, like scalpels. All those things will go to this puncture proof container, as you can see here. And blue vials is about glass vials, glass ampules, all those things. Atopa for the level of district hospital, CHC, primary health center, you do not need disinfection of glass vials. But for the case of sub health centers, glass vials, all glass vials should be disinfected before disposal. They have made it like that. This is dedicated area. Sigi potse kai kawi dedicated area for biomedical waste ki storage. What is this facility in the room? Let's, for example, in a district hospital, yellow bins are kept at 12 places. 12 places the yellow bins maybe minor OT, then injection room, OPD, consultation room, or labor room, maternity, OT, all those areas the yellow bins at the end of the day. Let's suppose at 6 p.m. the worker the sidagi workers in a low in a lakanda, you will keep the yellow, all the yellow bins and all the red bins you will keep it for 48 hours here, and then after 48 hours Sija will take it. After 48 hours Sija will take it sidagi. I know it is not practical, they do not come 48 hours but this is as per guidelines. Aduna moina akoina at least akoigi facility manungdadi 24 hours ti kaidongaida 24 hours ti manungda kaidongaida helhanbi ganobako dustbin mayamse. If it is 28 hours, just please transfer it here. Let it be here for a long time also, even if moisisa gi mi laktragba taragadi, or kaigumba akoida deep burial pit laitagadi, you first moi mayam je pull up oina sida khomjilaga thammo, aduga next day da sidagina deep burial pit to da transfer tawtho. Right. Then blue mayam just the puro blue mayam na amuk sharp waste pit the transfer tawtho. But as per Kayakal, as per NQAS guidelines, till the level all facilities the dedicated area for biomedical waste storage is mandatory. Management of shops I will not go deeper. Sharps key management, as we all know, because white leak proof, puncture proof container, the needles may amze loina hap toini khange. Post exposure prophylaxis and needle stick injury is very important. Sigisena kamaina sigise puncture proof container niko si yam tangi aduna sigise koina yam toina laibasu ngamdamina we will just stick to the old traditional chewing gum gi box kumba adugumba ko. So all this will be kept in the metal sharps. This is the broken glass ampule. So pick is over blues blues p is over. Akoigi district akoigi facility mayam sida what we can see is the blue bin is as big as the yellow bins. It should not supposed to be that. The glass vial adyam thoktabanina it should be smaller so that akoina kaigumba disinfect tawge haitarasu aduda tawdoini, and you do not need blue bin gi liners, you do not need it. Sidai sida dum direct hap khidoine. Needle stick and sharp injury or post-exposure prophylaxis key, there are many IEC materials which doesn't make sense. Theory for the level of subcenters especially, or for other PHCs or district hospitals or CHC, so let's make it simple. There are just 4 steps: clean, report, test, and treat. Test first thing is akoina prick ama tawgre. We prick ama laigre. Prick ama laigibadagi. Then first thing is we clean it. We clean it. Akoina we do not squeeze it. We just clean it with running water. We just clean it. We clean it, and then next thing is we report it. Report to the supervisor or infection control nurse tabu oiro for the level of subcenter gi di emo in charge the hiro na chagana PHC gi su emo in charge the call tawaga inform tawre hiro in reporting part is done. Reporting part is done, cleaning part is done. Now we test for BCR set to patient, BCR for healthcare worker. We have to test both patient kisu, healthcare worker kisu, numit to the adum, we will test it and we will keep the record. We will keep the report. May it be positive, may it be negative, we will just keep it, and we will start with the post-exposure prophylaxis. That should be done within 72 hours. The drug is called TLD, that is tenofovir, lamivudine, and dolutegravir. We have to take this medicine for 28 days. It is once a day dose. So this needs to be at the level of subcenter. You have questions on PEP also. So you need to know, first thing is prick you'll clean the site, you will not squeeze it. Second is report to the medical officer in charge. Third is you test it, and then test keep the results positive or negative, whatever. Then testing should be done for both patient and healthcare worker. Then you treat it with PEP, that is tenofovir, lamivudine, and dolutegravir, which is available in all PHCs and ICTCs. TLD is a charani 28 days charani once a day dose oidoini within 72 hours chahau doini, and then at the end of 28 days you test again. At the end of 28 days hidak charaba matungda you will test again. As per some guidelines, 6 weeks or so test but I don't know. But then for us, for this PEP NQAS you have to test after your medicine dose is complete at 28 days. That is the healthcare worker and the patient himself. Transportation and disposal of waste. These are some technical. I'll just skip it. Bins are not overfilled. Two-third everything should be discard. There is also one thing about, let's say, liquid waste. Liquid waste management ki subcenter ki level da amtang harange. I think most of the PHCs and CHCs, they have installed their own effluent treatment plant. So liquid waste management is almost done. But sub-centers in Gidi, like the Vanina, we follow the Karnataka model though. So when you have a basin here, this is your basin. Basin ki outlet to it goes to one jar. This is the table. Here you have a 5 liter of hypochlorite solution, that is 1%. This is 25 liter ki jar. Sida is a knob ama pale. Sida gisu knob ama pale. Here knob ama pale. Then this goes to the outlet. You have then elbow tap. Let's suppose this is your lab. Sida sida kano mayamama waste mayamama tagre. You go waste simyamse waste mayamama se tagra kansida makhazina 25 liters ki jar oidoni mathak kisina 5 liters ki jar oidoni which has hypochlorite solution 1% hypochlorite solution mathak kisila oidoni when sigise 2/3 fill tarakpa matamda you turn on this 5 liter ki jar aduga sigise full hello aduga then you can just go outlet see 30 minutes thamo and then this is your liquid waste management. Just amuktanga haige sigi kenose sida loin chatlani then 2/3 thalakpa matamda 5 liter ki jar do sida empty toksalo 30 minutes thamo outlet the thadokro. That is your liquid waste management. This is called as Karnataka model. Now, it's already 3:30. I'll take the quality management. Please take a break for 2 minutes. Quality management, say, I'll be focusing more on the some quality tools and prioritization part. It won't take much time in quality management. Outcome indicator, the sheet, calculate and then we will have a small session on IPHS. Please take 2-3 minutes break. Tamo, anything you would like to supplement?
I think it's okay. We'll take 2-3 minutes break.
So can we start? Quality management. Hello. How is that? Am I audible?
Yes, yes.
Yes. Yes.
Okay,
Yes.
okay.
Please.
So
We can start.
okay, quality management. Quality management. As we can see, there are 10 standards in this. Risk management framework, then clinical governance, risk management process. All these are not included in any atopa kanogumba CHC gumba facilities that yaude. It is only district hospitals. This clinical governance, risk management sugumba mayam sinago. But we have all this quality team, the form toba patient satisfaction, quality assurance, patient sigi anizena sub center giniko. Then sigi kenosiga mission vision policy work instructions adugumba mayam duga quality tools siga. So first thing is quality team. Second is patient and employee and patient and employee satisfaction, quality assurance program, standard operating procedures, process mapping, mission, quality policy and objectives, quality tools and methods. Sigi mayam sida focus tawgiseba. The first 7 standards of quality management. It's very simple. Ahambada quality team form taw haibani. First thing is, before you even implement NQAS, first try to form a team that will bring up that facility to NQAS level facility. That's very basic. NQAS ki just G1 the quality team mahana form tawro. Quality team do every month meeting tawhallo, gap putho analyze tawro, close tawro havenem. As simple as that. Second is अखोई की facility से until we measure कि अखोई की facility na piriba service से is it acceptable, is it affordable, सिगी मैम से अखोई ना अखोई की customer सिंग अखोई की client सिंग दगी feedback फंगद्रगदी अखोई improve तो बसुंगम गमोय. So the next standard is about employee satisfaction. At the same time, employee mayam sisu, they need to be satisfied with their workplace. Employee satisfaction. So G1 is quality team, G2 is patient, client, and employee satisfaction. Ahum the quality assurance program horem. Mari subada standard operating procedures, very big. Yam chawba standard nikosi kise. Standard operating procedure will define how a department should run. OPD the patient lakpada kadai the chattono, hidang kai the logdono, labor room ki patient lakpada kadai the pusandoino, doctor na kadai the laigadono, sister kaya phamgadobono, protocol combined design the way everything is written on your standard operating procedures. Standard operating procedures a frame the thamjan given training on standard operating procedure for the magi relevant department to the khaghan gadoini, so that everything should be done, everything is done uniformly. Hidak makta kapa BP makta one, but as simple as that, uniformly mi mana mi maga tawba thabak to chap mananaba standard operating procedure amagi makhada tawgadoine. Process mapping and improvement.
Cecil, Cecil, disturb to mat hoge.
Have you?
Afternoon,
Ha.
your voice is very clear. Now it's cracking.
Okay, 1 second. Please let me know if I am audible. Hello?
Yeah, it's audible. Sometimes the sound is becoming less, no? And then like that.
Okay.
Can you speak in a microphone?
Okay.
Near the microphone.
Now it's clear, Cecil, clear.
Now is it clear?
Yeah, it's clear.
All right. So G5 is about process mapping. Process mapping, the Aquina We do not learn process mapping. We learn from process mapping. Process mapping city akoina physically what is being done in that department. Huzik adugi department to the tauriba workflow do yektho kanda. We learn from that process mapping. It's not we learn how to process map. It's we learn from the process map whether the department is functioning properly or not. V6 deals about quality policy. As I have said earlier, quality policy is for the whole facility. Quality objectives are for different departments. Quality objective for OPD, IPD, lab, like that. Then last, akoina gap ama analyze tauba matamda sizinaba quality tools mayam ama quality gi methods mayam ama adugi matangda akoina discuss taudoineba in quality in G7. So first, let's see. I will be sharing the presentation and you can have a brief idea what all is included where. So first thing, quality team at the secondary level facility, the quality team se kana sadoino habada hospital gi medical superintendent, OT gi in charge or anesthesia in charge, ops gynae gi mi yaugani, lab ki services ki like pathologist, microbiologist moi yaugani, in charge nursing in charge yaugani, dialysis ki unit ki ancillary services id magi akhoi gi auxiliary ki ki lairiba mayam, transport ki service in charge, storekeeper, records ki in charge, sugumba mayam se pulla kanda, you will have the quality team at the level of district hospital. But at the level of primary health centers and sub-centers, for a sub-center, there is very less manpower. Primary health centers ki very less manpower. So whoever is interested in quality, who is like motivated to work, all can become a part of quality team. Quality team quality circle like quality team is for the facility and different departments ki quality circle like quality circle for laboratory, quality circle for maternity, OT, quality circle for labor room, like that. Aduga quality teams for the whole facility quality circle to the there is no much hard and fast rule so what needs to be checked while assessment the office order for formation of quality team at the hospital moigi monthly ki meeting records aduga monthly ki meeting record to the gaps discussed taukibaduga gaps closed taukibaduga record se haptoineba action taken is equal to gaps closed. Now, so quality team which is very easy. G1 the quality team G2 is about patient satisfaction survey. Patient satisfaction say monthly patient 30 patients per month Laura Kanda moigi feedback form yenghalani moigi feedback form duda taraiba score se kayano habase yengaga 30 patients se sumaina analyze tawrane. Like these are 30 patients, and at the end, we will know akoigi facility se patient na mark kayam pirige hai se khangdoineba. So that is patient satisfaction survey. We have defined format for patient satisfaction ki feedback ki defined format laire. As we can see here, OPD ki feedback form da for district hospital, CHC, primary health center. Aduk di we have 10 attributes ki OPD ki feedback form ama lai. Sida mi duna marks se piram doini. Availability of sufficient information, very good. Waiting time and registration counter yam kui nangai hargadi. Behavior of nurse to yam pai hargadi very good pirani. Waiting area the chair do yam kanna phajabu oide. Doctor do di yam pai. Time spent on consultation do matam yam pibi raktre. Availability of lab and radiological investigation free the loin tawbire. Promptness at the medicine distribution, pharmacist to noite. Availability of prescribed drug ti yam lairamdre. Overall satisfaction during the visits mind tawraga patients in akoida piramani sugumbaze akoina kuntra about 30 khomjalani aduga analyze tawdoineba. This is the OPD ki feedback format oidoini. This is the inpatient feedback format. Inpatient feedback format na waiting time at registration counter, cleanliness of the ward to ahum piramba, bed sheet mostly surrounding campus to the amnali doctor gi attention phatte attitude of communication of doctor adum yai time spent for examination yam nuaiti smain tawdana mana ama inpatient kisu piram doini sigi mayam se 30 khomjal laga khoina analysis tawdoineba. Then this is for subcenters ki di, as we can see we have 14 attributes for patient satisfaction. That includes regularity of CHO, time spent on counseling, adagi ashagi visit lakpa khotpa adugumba mayam amsu yareko. These are the model patient satisfaction formats. Next, how do we analyze it? When analyze the patient number 1 na piramiba mark mayam do smina loina yengthoe. Patient na piramiba mark mayam se loin yengthoe. Patient 1 na 4.2 ni pyramid. Patient 2 na 4.3 ni pyramid. Patient 3 na 4 ni pyramid. And so on piram bamatamda akoigi average amathogleeba, which is 4.2. 4.2 is our average patient satisfaction score. But the work is not done here. Akoina tawdoi kaino sigi mayam se si mayam sidagi lowest scoring attribute puthoktoineba. 4 phange yare 4 4 5 4 4 phange. Okay, sida these two parts we need improvement. Akoigi ultimate target se 5 phang baneba. Mayam se 5 phang bu yawe 4 phang bu yawe, but we are targeting this lowest performing attribute. And what do we do for this? We do kappa, that is corrective and preventive action, which is being done here. Promptness at the medicine distribution counter, the akoise 3.4 phange habni ko. Sigis is the mark yam phangde, sigis the mark yam phangde. And availability of prescribed drugs at the hospital dispensary. Ani is the akoise mark yam phangdreva. Promptness at the medicine distribution counter se mark phangdabanina kaidobe akoina medicine se ma je thiba phangdre hare ebang saigi medicine je sat piba matamda medicine thamba je kitang haphazard oibagi mana kitang oriented oidabagi promptly medicine je piba ngamdabani hareba ado gadi akoina ma je 2 weeks ki manungda training ama tawthoe then 3.4 leramba je next week the 4 da pukhaleeba. That is what we do. That is kappa, corrective action, preventive action. Next, sige se akoigi lowest scoring attribute ta tawgadawni ko 3.4 ama yaw na akoina 4.5 ki du da tawshin baya de ko line. So corrective action, preventive action should be done for the lowest performing attribute. Here 3.7 is in the lowest, 3.4 is in the lowest performing ni 3.7 the su tawbe prescribed drugs mayam se lairamdre hai. Laitri se kadaway no hang matam da Indian matam chana tahogda bayni Indian matam chana tawdri se kay gino hay matam da mana hot pa matam da buffer stock reorder level mayam se hot khidre na hay. So we train them. Forecasting of the drugs is done. Buffer stock thambiba, reorder level thambiba, timely indenting tawbiba. Then 3.7 sidagi yam natragasu next month 3.9 the hengala e haveneva. So this is what kappa means. This is the patient satisfaction survey gi analysis. This is the patient satisfaction survey gi format. Sigi format mein humse patient kuntra gi khomjal lakanda we analyze it. We find out where do we stand and where are our lowest performing attribute. That is here. Adugi lowest performing attribute gi akoina kappa tawthoeba. All right. So internal and external quality assurance program. Due to this time constraints, I'm gonna just little bit kitang samjan geko, but I will not miss the most important ones. There is this thing called as the internal quality assurance, and one is the external quality assurance. External, whenever we say we send the sample outside. Internal, we do it inside only. For example, let's say lab amada hire se bako. Lab amada internal quality check tauge. Hai taragadi if we test for hemoglobin, we take the same sample and then we test it thrice. 1, 2, 3. 3 times however. Same sample and then we test it 3 times. One comes like 9, 1.9.2, one is like 8.9. So this is adum yaeba kashukai deba. The problem is when we test the same sample, hemoglobin ki test se akoina 9 ong laba, 12 ong laba, 15 ong laba. Then there is something problem. Machine needs to be calibrated or something is there. Staff ki competency na soira. That kind of quality should be checked. Aduga kaidobagi lalino haibado puthokodoineba. That is internal quality assurance. Internal quality assurance lab kina adu oire. Internal quality assurance amasina atopasina NQAS ki checklist akoina internal assessment tawjagumba. Kaya kalki akoina internal assessment tawjabagumba. That is called internal quality assurance. Now external quality assurance is when you test a LFT. It is done by Krishna. Sigi port se they send to Babina. Any NABL accredited lab amada they check whether the LFT gi parameter muida phangiba mayam se muida su chap manana phangbra haina, or Babina or Jennings or RIMS or wherever muigi kanoda certified lab amada tharakanda muigi result mayam se check tawna ba haitara. So that is external quality assurance. Internal quality assurance study akoigi NQAS ki checklist kaya kalp ki checklist adugumba mayam do oire. External, which is specific to laboratory, is done. Internal within the lab, external is outside the lab. Internal the routinely tawe whenever you open a box of dengue rapid diagnostic kits. Aduga same sample the dengue kit ahum da taklauna tawba matamda same sample do ahum positive tholakadawne amana positive amana negative amana negative thok targadi that needs to be checked, or values protein sugar yengba matamda amana amuk high oiba amana amuk low oiba thok targadi that quality is not maintained. That is called internal quality. External quality is to send the sample to another lab so that we will check our report results. Sigi pick charts. I will not go here right now. We will go to the prioritization section and then we will discuss that later. Now, let's see G4. G4 is about standard operating procedures. Standard operating procedures should be there for every department. There is customized Tauraba format loina lai if needed. We can provide, just have to customize it as I've said earlier. Then G5 is about quality policy, quality manual, work instructions, records formats, and SOPs. Quality policy, for example, let's say this kind is a quality policy. Quality policy hai targadi akoigi facility sigi magi vision akoigi kano policy ma hai tare. It doesn't change in some time. It's for a longer period of time. Akoigi magi policy neboko. So these akoina for a district hospital also, for CHC also, different quality policy lai amadagi amadum akoina chap manaba akoi mayam gi mission dudi chap manaba nina akoigi sigi mayam se tum mana doi neboko. So these can be framed. Then quality policy is for the whole facility. It can be atupadagi adum low by example, our hospital is committed to providing timely patient-centered and safe outpatient care. This say yamna koigi yam objective yamna koigi targeted oiba natte dana ko aduna kashu kaide ko koigi just pandam dune. Quality manual is quality manual and amalai quality manual is all about all those quality ki related oiba documents noigi HR gi noigi village ki noigi process mapping tawgibagi quality tools sizinagibagi department SOPs work instructions, all those files kept in one big file, that is your quality manual. Quality related oiba pot mayamama adudai loin yawarga laine, but that is called as quality manual. It will start with the history of that facility, population ki demographics, HR ki status, number of awards noina phangiba, then quality tools sizinagibba, patient satisfaction like give us standard operating procedures, work instructions, all those things manung daloi hapakanda, that becomes your quality manual. Then standard operating procedure yare work instructions hai taragadi, it is a part of standard operating procedures. For example, standard operating procedure for lab sigi manung da work instructions for rapid diagnostic kits yawram ganeva. Standard operating procedures ki manung standard operating procedure for labor room sigi manung the work instruction for management of postpartum hemorrhage yarom ganeva. So that's the catch. Records and formats, documents capturing evidence, process cd okay form kai kam do loina thammo haibani ko. Process mapping. Now process mapping hai taragadi, as I have said earlier, we do not learn how to draw process mapping. Instead, we learn what is going on in that department from the process mapping. Process mapping, we just have to know how to draw. Process mapping, we start and stop with the oval. All those processes we keep inside a rectangle, and then we keep a diamond if there is any decision, yes or no, positive or negative. We keep a diamond. So simple oval lamane, rectangle lamane, diamond lamane. Ahum sina process mapping. Example ama lokhalaga yengsi patient ki registration gi niko. Patient arrives at the registration desk. This is start and this is stop. Patient arrives at the registration desk. Start tawre. Is there a line for registration? This is, what is this? This is a decision. Decision, the line magadi patient waits till called lairam dragadi patient in a clock the hangim. Kai the lep to in new patient the kaigumba, the line waits till called, patient sees the clerk. Line the left targadi one by one changar niko, first come first serve ki basis ta line later na pangchang changar e mayam se. Patient sees the clerk, new patient or existing patient hangi e, new patient fills out the paperwork, existing patient organa from the chatle sai sida half hazard khara oire ko. Sai sida sorry see with the line lepe. Then sumain tawdana doctor available oibra oidabra. Sumaina si kisina yamna basic oiba process mapping ni. Process mapping can be drawn akoina arrival of registration counter da lakpadagi, anaba yengbadagi, pharmacy da changbadagi, sample collection lawbadagi, laboratory da changaga test tawbadagi, labor room da angang popadagi. Many other process mapping can be drawn. Aduga process mapping je kamaini ye kadoino habanate akoina huzizik akoigi facility da tawriba workflow do adugido chi da tathokpa khataneba aduda lan ba chumba haiba kembo laite puthokadoi kaino non value added services mayamse, non value added set steps mayamse adudagi longthorakadoi kaigumba gate the registration ama tawraba, doctor manakta su registration am tawraba, pharmacy da su registration am tawraba, lab da su registration am tawraba. So there are lots of registration, lots of time has been wasted on that registration. Why not just one simple registration, one single number, and then patient ki time waste out the bida zara chatkibado ya bra habado adudagi puthokadoi process mapping dagi. So the main idea of drawing a process map is to take out the non-value added services or non-value added steps. Kanada bada repetition laivasing do adugumbado longthoknabane ko. So that is policy. So that is process mapping. I hope it is clear. Then see mission vision ke case ma yare ko. Then let's say quality ki objective and amalebo ko. As Tamo have mentioned earlier, this also have to be framed. Quality objective should be a SMART objective, that is specific, that is measurable, that is attainable, that is relevant, and that is time bound. For example, CHO mana magi telemedicine se yam sole 2% khak lai my telemedicine gi magi target achievement se adoi targadi magi tawgadoi se specific oiba telemedicine se kaida tawni e-sanjeevani da tawni, which is very specific. Measurable hai targadi 2% tagina 10% baudi hengal hange haiba. Attainable oi ni ko se aina 2 dagina 100% bo hengal kani haiba dudi attainable oi drev. So 2 to 10% hengal hangani haibane. It is attainable. Telemedicine is relevant in your performance evaluation. Time bound, that's 3 months. 3 months ki manungda aigi hana 2% lairambado, we have to increase it to an attainable, measurable 10%. That will be done in the next 3 months through e-sanjeevani. Taugani haibane. This is a quality objective. Objective ama semge hai taragadi ai khoida gap ama natragana problem ama laitragadi sembe yadeba. We cannot make an objective for something which we are already good at. Akoina already koi delivery normal delivery tha amada 60 tawe haga adugi objective thambagi darkar oideba. Problem is objective is only made when you get 10 normal deliveries in a month and 30 CS. Adoi taragadi normal deliveries hengat nanaba objective ama semba dunya. When we have akoigi kenose akoigi normal ga CS ka gi ratios no CS about normal delivery ki ratios 50-60% tagi some for 30-40% lai taragadi we have to increase it. Adugumba ama laiba matamda we make the objective should be made for every department, and we cannot make the quality objective for something which we are already good at. Akoida achieve tawba ngamdaba pot amada objective same doini time bound oidoini time bound se generally 3 months ta akoina 3 months kudingi akoina semi 3 months to the achieve tawba ngame very good 3 months to achieve tawba ngamdre nasagi 3 months the 2 to 10% in 3 months ta achieve tawgani habne ngamdre kaya di ngamgrageva 8 phodi ngammeba 8 to 15% 8 to 20% na mo next to the onthokpiyoba le after 3 months that is fine. So quality objective should be made for every department, may it be labor room, maternity, OT, or any other pediatric ward, SNCU, whatever department, quality objective amamam laigadauni moigi khwaidagi hen asonba part to pukhalakna ba. And quality policy is for the whole facility. So these are some kinds of magi kenoduniko objective tuniko. Then let's do some quality tools. Very interesting. People think that quality tools are very tough or very but it's not like that. Brainstorming the quality tool mapung phade. What is quality tool? What is brainstorming is you sit round table amada mi mayam phambiro problem ama table da thambiro aduga sigi problem sigi cause mayam se whether it is relevant or not relevant, just say it on the table. Table to the problem to gi cause mayam se loina thambioba. What may be the possible cause of that particular problem? Adu giduna cause ki brainstorming, or what can be the possible solution for this particular problem? That is also another brainstorming. What is brainstorming? Hai taragadi mayam dagi comment se lobudunevoko. So that is brainstorming. Whenever any problem is there, first start with brainstorming so that you get an idea about the cause of that problem or the solution that can be done to solve that problem. Brainstorming hana tobioba. Brainstorming tomatamda quality team ama loin yarni any relevant department dagi mi me am kobiro phambiro round table amada and then just burst with ideas why that problem is happening and what can be the possible solution to solve that problem. Now, why analysis and why analysis, or we can say 5 why analysis. I won't go to the theory. I'll just give you one example of what why analysis is. Let's say there is a problem where bed sheets and linen are not changed in the IPD wards. The medical superintendent has been furious that the IPD ward bedsheet mayam say chunga nande na saure aduga bedsheet sister adum taina banang keno je bedsheet se mole na. So what is the possible cause? When root cause analysis, when why analysis was done, first why we asked was no clean bedsheet available in the ward. Sigi why say no washed linen from the laundry since 2 days. Laundry dagi linen asuba lakte haire. Adoi taragadi kaidobagi laundry dagi laktre no na mo hangba matamda bed sheet mayam do sudri haire laundry da. Why kaidobagi sudri no haiba matamda ishing ta de haire. Ishing ta de hai taragadi when asked irregular water supply from the department and small water storage tank. Irregular lakpa matamdana ngasai tank se yam pikpa adu natragana lakpa matamdana tank se pikpa aduga matam chana laktaba si oirambe ai Another why sida atopa amasu tawe tenki kai leramsu yawe. Tenki kai leramsu yawe. There was this instance where the tank was broken. So in order to have clean bed sheets in the ward, you need to repair that tank, or you need to get a higher storage tank facility laibam changeba. So it's a very different root cause analysis. Why analysis? Another example is patients are not satisfied with the cost of treatment on medicines. Patients are not satisfied with the cost of treatment on medicines. Prescribed in the brand name by the physicians. Brand name. Clinicians think that most of the medicines are not available in the facility. Laitabra khalleba akoigi store da lairiba hidak mayam do physicians na laiti na khalluiba. Then clinicians are not kaidobai no haitaragadi clinicians the awareness to what pagi that they have sufficient drugs. Then adugi why amu hangtaragadi pharmacists did not communicate with the clinicians. Then adu kaigino haikanda pharmacist assume that it is not his or her responsibility. So where do we target? Where do we solve this problem? We solve it here. We solve it here. We solve it here. Akoigi kenose. Kadai jagada akoina act tawgadawno haise bed sheet laite hai targadi tenki shemjan bana traga tenki anoba ma laibiba sigi scenario sida then sigi pot sida oitaragadi magi pharmacist sing se akoina mongonda keno tawbibam change pharmacist sing sida noi doctor sing da awareness pigadawne na mongonda target tawbam change then only physicians will start writing the drugs which is available in the pharmacy. This is an example of root cause analysis, that is why or 5 why analysis. 5 haidi why manga the lotion baniko. Like we use only 5 why. It's not like why we generally we use 5 why, and then we get the root cause of what the actual cause of the problem is. Then why amaga general flow amaga haige delay in the response. Delay in response by nurses and ward boys to patients staying in the ward. Staying siko. After YY, PDCA sing seloin tawdoineba. PDCA hai taragadi ultimate problem solving method si oidoiniko. So first Y is delay in response by nurses and ward boys to patient staying in the ward. Kai no communication ward pagi. Kai no frequently mana ngasai staff sina frequently patient calls se attend tawba ngamdaba. Kai no hai kanda yang kuina ma se DT tasalakpagi oirammeba. Kaino hai kanda moida stop watpagi oiramme habaniko. Doi taragadi response to phajadri do natagana response ta tappi do som the stop watpagi ne habagi YY gi analysis ni ko sigi se. So when we do PDCA, it goes like this. Every quality improvement tool that you use should be followed by a PDCA. Gap close to give us a PDCA that we will go in the subsequent slides. I guess everybody is clear about 5Y. Now let's see fishbone analysis. Fishbone analysis is very easy. It is another for sub-center dosu yaudo niko. Sub-center ki parts in high brainstorming, very important. Quality tool ama how ge hai targadi brainstorming na dum how you why analysis. I think everybody is clear. It's very easy. Why ahumira hangdabaduni mangara hangdabaduni. Then you get one root cause. Root cause to akoina gap to close to baduni. Now let's see what fishbone analysis is. Fishbone ki diagram se sumaina layebo. Sida problem do say irani aduga magi bones mayam say akoi ki keno mayam se possible cause mayam se say loi idoinebo. Possible cause mayam se say idoinebo. Let's see handaki thada newborn deaths mayam ma yame. Newborn deaths se yam khal eboko. We have high number of newborn deaths. We don't know what to do. Why is it happening? We don't know. So what we did, we had a brainstorming sessions. We called gynecologists, we called pediatricians, we called sister in charges, we called multi-purpose workers, and then we sat down, we had a brainstorming sessions, and in that brainstorming session, all this were stated by the members who were on that discussion. Partogram maintain tawdabaini haire sister in charge na. ANC do mamari dagla amdabaini haire. Hygiene maintain tawdabaini and hire payawe. Political interference like paini hai. Nutritional deficiency like orangani hai. Oxygen like madi shiroi dongni hai. Disinfectant like tabaini hai. All this were the feedbacks which was given through brainstorming. Brainstorming tawraba matungda, we get all these attributes, and then all these attributes we kept it in a fishbone fashion. Measurement ta partogram maintain tawdabaini, ANC tawdabaini, ANC the danger sign mark tawdabaini, ANC tawbakan the high risk ni haibiram dabaini, labor room gi understaff oibaini, fluctuating power laibagini, poor inventory management laibadaini, political interference laibadaini. Sigi mayam se measurement ki problem la, material laitabagida, means thokhalibra, method soibagira, machine yadabaira, environment ki problem oibaira have to say we analyze it through fishbone diagram. But to have a fishbone diagram, it is important for your team to first have a brainstorming session. Brainstorming am tawraba matungda sida magi reason mayamam thogla ne, cause mayamam thogla ne. Sigi cause mayam se you write it in a fishbone fashion. Segregate tawthopiro machine yadabaina karambano, environment kina karambano, personal training watpagina karambano, measurement system soibagina karambano. Then adugi mayamdo as per this you write your problem here and then your fishbone chart se sumaina same kidoineva. So it's very easy. You have a problem, have one brainstorming, list out all the causes, and then write it where it is applicable in your fishbone chart. Now, I will not go to in this details like a run chart, histogram. These are all kinds of quality tools. Akoina use tawdaba quality tool. Now, let's see what a prioritization is. Akoina PHC ki checklist, district hospital ki checklist ta quality tools ani sizinaro aduga prioritization ki tool ju sizino hai. Prioritization tool da there are two kinds. One is called as the pick chart. One is called as the Pareto's chart. Let's take this same example. Sigi same examples Sigi same examples. Where let's take this same example where partogram not maintained, radiant warmer not working, ANC not done. Sigi 27 reasons label for high newborn deaths. 27 reasons for high newborn deaths. 27 reasons sigi manung dana. We have to find out which ones are easiest quite a line of solve to wayaba nipanam yarming kalaseba. Kitang possible oiba taram yarme hair challenging oiba manga mayorme hair aduga out of 27, let's say 7 or 9 the akoina upay shungai laitre hair out of those 27 there are 8 causes which we can close it immediately. Partogram maintain tawramde immediately implement away adugi poto I the thambio kaigumba possible oiba yadi yaba aduga yam sukana gadoba but effort kitang di changadoba you keep it in the possible region. Now the wadi wagadoba but adum effort thada taragasu if you give effort but then you get some outcome then you keep it in the challenging ones. And then there will be some parts where even if you give a lot of efforts, you're not going to get any outcome. You keep it in, kick out. So possible, implement, challenging, kick out or kill it. Out of those 27 reasons, I amadi immediately implement the in the next 1 week. Sigi Aitsehan implement over. This is actually applicable for your NQAS implementation also. Take out your NQAS checklist, assess it, internal assessment, those checkpoints where you get 0, mark it as whether it is P or is it I or C or K. If it is I, mark, keep it aside, keep it like immediately nang taunanaba thammo. Mark all those checkpoints where you get 0. Mark it P or I or C or K. If it is I ma'am, and then first start to do those I first. Within 2 weeks, your score will increase from 40 to at least 50-55%. Then you start doing the P ones, you will get 75%. You do not even need to do the kick out, and you do not even need to do the challenging ones. So when you do your action, when you do your assessments, always if you are getting 0 on a checkpoint, mark it as whether is it possible, whether is it implementable, whether it is challenging, or whether it is kick it out, or whether it is kill. Kill give to the next time it's okay. Implement mayam do hana loin but list out biro in the next 1 month or so. Try to fix those, try to close those gaps. So that is the picture. This is the prioritization tool. Prioritization tool na kaidoge have out of these 27 causes, we cannot solve all of them. So what we do is we solve 8 first, and then subsequently we solve 10 more, and then we try to solve this 5, and then we leave out this 9, which doesn't have any outcome. This is called pick chart. Now, a very interesting Pareto chart is, it says 20% cause, 20% of the cause, 20% of these 27 sidagina 20% sinana 80% issues at 20% of these 27 will be responsible for 80% of the actual problem. That is a 20-80 rule. I'll give you an example how it is done. Pareto's analysis Shigi mana hai se 27 sigi manungda 20%. So 27 gi 20% hai targadi, let's say 4 has a book. Shigi mari se Shigi shina 80% of the nasagi newborn dead set. It doesn't really account much. So if you target these 4, then your problem will be 80% solved. Pareto analysis, nice. So when you have 100 reasons that you need to solve, just take out the 20 which is causing 80% of the problem, solve those 80, and you will get significant results. Let's say the Pareto analysis of prescription audit. Let's say a prescription audit was done for a hospital for the results of 100 prescriptions. 100 prescriptions ki akoi the Pareto analysis and the result is without the name of the patient. Akoi Pareto analysis not satisfactory. Karigino yengo matamda maming yaudaba patient ama yarme, registration number yaudaba ahum yarme, history yaudaba mari yarme, generic name na iramdaba kuntrani pan yarme, salient feature of clinical examination idaba ahum yarme, duration of treatment mentioned taudaba ama yarme, handwriting phazadaba mayamam yarme. That is why akoigi prescription mayamse koina phazana akoi not satisfactory oisineba. So what Pareto analysis says is, sugumba put ama phangba matamda we will akoina smaina analysis taunana ba table amamamdi same nebako. Table amamamse frequency se akoina sigi my 1 3 4 38 3 1 34 si mayamse. Please listen to me. Sigi matangse kitang concentrate ko. Please attention amta PBO. Sida laidiba frequency mayamse. First thing akoina descending order da pukhalaneba. Descending order da pukhalaga di 38 chana quite yam laire, next the 34 laire, then comes 8 6 4 3 2 like that. So descending order da hana thammane basimyans. Descending order da thamba matamda sigi se 100 ki manung da kaya no yengani aduga next ki lakadoisina cumulative percentage lakadoisa siga tinchalaga out of 100% ki manung da kya no sigi ahum je tinchalaga out of 30 or out of cumulative percentage kya no sigi mayam mari magse tin jalakanda out of percentage kya tage na sigi cumulative percentage amamam ine ba frequency se ahambada descending order da thamani descending order da thamaba matungda sigi percentage out of 100 38% niko out of 100 38 plus 34 se kya percentage oire 72% oire siga punjalagadi 80% tare sige punjalagadi 86% tare then sige se horen akoina graph oina yekthorakpa matamdadi what we can see is this two, that is the 20% of the problem is causing see 80% of the can we say mana cost oram prescription audit phajahan ge hai targadi shigi mayam se shida focus sungtau tawdrasu sigi ani si khaktang da focus tawba matamda prescription audit ki score phagalakane habane you don't need to increase the prescription without diagnosis or we just have to write the generic name of the medicines we just have to write the handwriting kano taw phajana iba so akoigi prescription audit taw matamda marks yam phangde kanam kem tawbiyo yade na hai analysis am taw targadi only 2 points we need to change that is doctor gi handwriting duga magi generic name na ibaduga ani du khaktang improve tawba matamda this prescription audit ki can we say loina solve tawe so that is Pareto's analysis and that is the second prioritization tool ani lai aham baisana pick ni which we have discussed here implement khudakta tawba abado tawro next possible lao implement ka possible ga loiraba matungda challenging lokhatlo challenging do tawba ngamaga di phare ngamdrasu it's okay kick out to the don't even try Pareto's analysis 2080 rule out of 10 causes which is causing the issue 20% of those causes khara yarongani yam hena affect tawhanba let's take another example anyway then comes 5S which all know lean six sigma hierarchy khangnai sort set shine standardize and sustain which we use in kayakal mayam loin khangbi ramani then lastly we go through PDCA is plan do check and act plan do check and act isu I will not go to the theory lu idore ko please plan do check act se practical oina haizage let's say we have a problem the time taken during the registration as on 30th October 2022 is very high that is 30 minutes akoina registration ama tawba matamda matam yam changi habane registration counter the waiting time is 30 minutes changi what to do adu tawba matamda PDCA da akoina sum check tawdone ba kai tawragana phagadage habase PDCA is ultimate quality improvement method nebako so what do we do is first thing we allocate responsibility of registration to lab technician amada akoina tawhal leba lab technician amada nang register tawba haibanina nang tawna register tawhanba ma data operator anoba ma tawhanba ma signage registration counter se karai adudai thokraga karai da lay registration counter se na karai da lay adugi signage extra khara hapchan ba ma aduga registration counter amma extra hapchan ba amaga sigi steps mari se akhona lokhat le sigi steps mari sida is the karambana kanari no karambana kanadri no have se PDCA na harakadoi ne so our problem is waiting time at the registration counter is very high that is 30 minutes the actions that we are going to take is number 1 lab technician amada ticket kan ba ma ani shubada data operator hapa ma ahum subada signages install tawba ama mari shubada registration counter extra amaga hapchan ba ma so let's see how PDCA does number 1 the plan is to allocate the responsibility to the lab technician do ticket ka pa haure ko lab technician na ticket ka pa hau matam da akoina check tawru matam da ma ticket sum kaktana laire magi lab ki thabak mayam do loin kaithare then this is not a good idea so we discard it action the kaino discard tawgreba koina. Plan is to allocate the responsibility to lab technician, which we had planned. Lab technician duna ticket kakpa hore check tawruba matamda hengalakpadi kanu hengalakpadi lana asumda lab ta loin kaire, then we discard it. This is the first action taken. Second action taken is data operator anoba ma koina hire tawre. Aduga mase temporary data entry operator appointed for 7 days to make entries. Si tawruba matamdadi amok burden on finance tawre. Koigi financial burden achauba mala ema hire tawbagi pesha laitabagi. Aduna discarded as it requires extra resources. Yeah, behind go. Am I audible? Am I audible? Am I audible?
Yes,
Cecil
yes.
tie, tie.
Okay. All right. So this is the second scenario. The third one is akoina implement the signages for easy movement. Let's see. Signages se kai gumba akoina hapchan taragadi akoi plan se to implement more signage. Broad and clear signage mentioning registration counter were made displayed. That is, we did this, and then when we checked, 5 patients availing OPD services were asked if the signage were useful, and they said yes. She kanai hare handai hare hana 30 minutes oirambado at least 24 minutes the handhare. Then we accept it. Act ki part so that we accept it and then we implement it. So mine dana PDCA same never. And the last one is registration counter. Anobama same has plan to make another registration counter. Team planned for building a separate cabin, not able to build due to resource constraint. Akoina kenoma registration counter anobama haptaragasu manpower computer ke kalo like they are damina. That is not very practical. So we again discard it. So this is kind of PDCA, simple PDCA that we can use at our facility level. PDCA si yekpa matamda akoina ngasai dagi sigi diagram just mind to yi is sigi is the just gyan tanaba yekpani ko at your facility level sumaina adum samjallo. What is your plan? Plan is allocating responsibility of registration to lab technician. Lab technician allocate tawre, check tawru matamda kanaramdre, then it is discarded. Signages for easy movement, akoina plan tawe, signages hape, patient mangana kanai harme, 30 minutes to the 24 minutes the handare, we accept it like this. Very simple, plan, do, check, and act. Check, say, always, please make it measurable. Haibadi 30 minutes togi 24 minutes the puthari ekana. Let's just make it measurable. These are some of the examples. Mamanga Taukiba PDCA PDCA the problemum laini prescription of branded medicines in place of generic medicine by medical officers yakona PDCA Taubumatamda plan to increase the prescription generic medicine ihan baduniko. Kai tawi medical officer mayamda ideally matanga training tauki orientation to medical officers regarding prescription audit to make available the prescribed generic medicines in the pharmacy. Check tauruba matamda mamangda 31.25% tagi 60% ta akoigi medical officers mayam sina magi prescribe can say generic medicines e iba haure hainiko adudi si se positive impact lairabanina continuous orientation of medical officers are done. All medical officers now adhere to the ideal generic name. Example niko. Another example is general flow. General flow. There is one problem, that is low bed occupancy rate. Low bed occupancy rate for the level of PHC district hospital. This is for PHC. PHC the tau given is low bed occupancy rate laire. Akoigi inpatient ki count se yam name then what may be the possible causes ana akoina brainstorming taurumatamda sigi reason mayam se loin thogle sigi reason mayam se loin thogle akoina brainstorming taurumatamda. Then what do? We have collected feedback from the patients. Why are you not getting admitted to this hospital? Adamain tau matamda mi kunma thoi mana aidi yum na pai ni hare mi trying to amana noi hidak phangnam da bai nge haire tarama thoi amada noi lab ki service se phajada bagi ai dum ada chachara bani haire atai di 63 ke myam ma yam da bi da haire ba. So this also, when we take the Pareto analysis, ahum je akoina kai gumba solve tau gitaragadi, we solve 80% of the problem. That is Pareto's analysis. Aduna sigi 100% sigi manungda, if we try to solve this three, if we make the 24-hour lab services, medical supply hengalan taragadi IPD ki patient ki count se hengalakani haibanevoko. Aduna, we do not need to solve each and every cause that is hampering our service. We will try to prioritize where we have to hit, where we have to solve the problem, where we have to close the gaps, and then automatically 20 lermado IT mathakta laksagani habaneva. That is the beauty of Pareto's analysis. Now, sigi potse tauraba matungda sigi ani si khaktang tauragadi yani habanina adi se hengatlaga PDCA da thadare. PDCA da sporadic supply of drugs and medical supplies, lack of 24-hour services, lack of private ward, this is the probable cause. We have planned to increase the drug supplies, increase the working hours of laboratory, do the lab staff test then bed occupancy rate is increased from 3.8 to 8.6 in July 2024. Kanai positive impact we act, we implement it, we 24-hour lab services private ward ama tungana thamme sporadic supply of drugs and medicines to regular supply the then we can increase our IPD bed occupancy rate from 3.8 to 8.6. That is PDCA, and this is the general flow. When you have a problem, do the brainstorming, all reasons will come out. Out of those reasons, prioritize the causes through pick or Pareto, and then you draw a Pareto chart. You will find out there are only two or three reasons that is actually causing the problem. Try to solve those two or three questions. Try to solve those 2 or 3 gaps, and then you will have significant results. I will not talk about clinical governance. It is all about risk management, patient safety, effective. It is mainly done for district hospitals. It is not included for CHCs and PHCs and sub-centers. When time comes for district hospital, quality part when we have problems on clinical governance only, we will deal it separately, we will support separately. All sorts of audits and everything will come under clinical governance. So I think it's 4:30. I was thinking of doing IPHS also, but I think everybody would be wanting to leave. So Tamo, Dr. Steve, if possible, we can have the IPHS ki session do no matau sira hauzik tau siya su kashubidi kaide, but I think everybody must be tired by now. Please comment.
How long will it take?
Half an hour about.
Half an hour.
Mm.
Okay, up to Steve. 1 minute. Okay, we will continue, Dr. Cecil, IPSS.
Okay.
Cecil, are you there?
Yes, Tamo. Am I audible?
Yes, yes.
Okay. Is my slide visible? Is my slide visible?
Yes, yes.
Yes.
Okay. So I'll just have a brief introduction about IPHs for district hospitals and SDH. So SDH का district hospital की IPHs standards था not only about district hospital and SDH. We have just like NQAS for IPHs also there are 7 areas of concern. First one is the infrastructure. Second is human resource for health. Number third is medicines, diagnostics, equipments, quality assurance, and clinical governance. Clinical governance is somewhat similar to the clinical governance that we have in the district hospital level. It is all about your citizen charter, all about your policies and all those things. Quality assurance, the NQAS labado adum laizare. So 6 and 7 is all about documentation. Now, infrastructure, human resources for health, medicines, diagnostics, equipments is the main area that we focus. And then, IPHS ki through the ODK tool, mayamna assessment taukhibadu that was not done very well. Hadi mayamna IPHS ki matang da yam kana khangdringai da adugi kenu dusu dum tausan grai tar adugi assessment to sudum tausan, but it was done second time today. I think it was significant changes were seen in the IPHS assessment. Adugi matam dadi mayam khara keno tauraba male ko adu matam dadi mayam khara oriented oiraba male. Anyhow, we have 5 areas of concern which we need to focus on, that is infrastructure, human resources for health, medicines, diagnostics, equipments, quality assurance, and clinical governance. Before we begin, population and bed as per IPHS, desirable beds say less than 2 lakh ki population oitaragadi, desirable beds is 100, but 50 beds laitaragadi ngasagi NQAS tasu yauba additional 15 additional beds amadi thambam changiko. Population say 2 to 5 lakhs ki oitaragadi should be 100 beds, between 5 to 10 lakhs oragadi 200 beds, 10 to 20 lakhs oragadi 300 beds, 20 to 30 lakhs oragadi 400 beds sumaina laiko magi district hospital ka SDH ka gi magi bed ki strength laibam thokpase. Another is the door to drug magi service flow se akoina IPHS ki norms ki matung inna patient se laaba matung da mana hidak laroga chatkibagi workflow se Sidaisida akoina akoigi process mapping do design tawdoini ko inquiry tawbhamam thamba registration with inquiry for accident and emergency is triage. Then registration, waiting, nursing station, clinic, dressing room or injection room, diagnostics, drug dispensing. Sidaisida actually loire, but mera hospital gi feedback piramba ama kaigumba mera hospital do koina kenu oitaragadi mera hospital ze koina implement tawtaragadi adugi potuma feedback system ama lakadoini ko. So inquiry, registration dagina masagi drug dispensing gi counter for. So these are the 7 areas of concerns for IPHS. Let's see what infrastructure means. Infrastructure the ani yawe general appearance and upkeep ka other support services ka. General appearance and upkeep is akoina kaya kalp tawbuduga chawrangna dumane ko. In the infrastructure part of IPHS, general appearance and upkeep the yauriba pot mayam se wayfinding signage, parking, gardening, landscaping, facility ki entrance,
friendly features, disabled friendly access, circulation or corridor areas, ramps kumba, reeling kumba yawba mayam NQAS te yawba maina, disaster and emergency preparedness, electrical and power supply, adequate fire safety, illumination, water supply, draining and sanitation, waste management, aduga last infrastructure for clinical services and amayaga. So these are the general appearance and upkeep that we have to yengadause. Ado sigi sina aina just heading moina haibani ko wayfinding signage se moina road tagi dum thethiat pa horo haire parking se asuk chawba ambulance khamasu chanba or two wheeler gi tongana four wheeler gi tongana adumaina details mayam ama piri adugi do atopa kona ai presentation ama oina share tarake ngasi gi disaida akoigi kenosida dum loiselaje akoigi heading sida ko. So please understand area of concern 1, that is general appearance and upkeep of infrastructure sida wayfinding signage, parking, garden, facility entrance, illumination, water supply, etc. Sugumba mayam si yaure 1 to 14 sida. But in case of serial number 15, infrastructure for clinical services, infrastructure for clinical services sida amuk mayamam yauriba. Those are for a level of district hospital, outpatient services, registration area, waiting area, nursing station. Outpatient services, registration area, waiting area, nursing station, consultation room, examination room, adolescent friendly health clinic, counseling room, sound treated room for audiometry, PFT, ECG room, health and wellness room, yoga gumba integrated clinical and public health laboratory, medical imaging center, drug dispensing counter, emergency care, burn unit, dialysis unit, critical care unit, OT complex, labor room complex, special newborn care unit, mother and newborn care unit, DEIC, nutritional rehabilitation center, inpatient wards, communication systems, record keeping rooms, store rooms, knowledge hub or IEC corner, and administrative unit. These are supposed to be there in IPH as per IPHS guidelines in a district hospital. Then this is called infrastructure for clinical services. General appearance and upkeep. Next, let's go to the other support services. Other support services tadi kay kayawi blood bank and blood storage unit. Sige mayam tadi essential oiba khara am yawi, desirable oiba khara am yawi. Centralized sterile supply department. Kaigumba district hospital the centralized sterile supply department later agadi labor room gi tongana dagi atopagi jaga jaga gi tongan autoclave taurise taunararoi centralized oiba autoclave tawbham mama linen dagi kai dagi moi loin sterile tawraga pirakpa ama ada layerne. Hospital gi laundry, dietary services, medical gas pipeline systems, residential quarters, guest house, mortuary, toilets, si mayam se other support services ki oina laibham thoi mathau tai haibani ko under Indian Public Health Standards for district hospitals and sub-district hospitals. Let's go to the second area of concern, that is human resources for health. District hospital the kari HR laigadobano do yengsem. First thing, human resources for health, the 2.1 is administrative staff, like the medical superintendent, like quality manager, a hospital manager, infection control nurse, all those things, administrative staff. Then doctors, specialists and medical officers, like nurses, different areas, the critical area, gi tonganba nurse, OT gi tonganba nurse, emergency tonganba nurse, labor room complex ki tonganba nurse, OPD in other areas ki tonganba nurse. May it be amani or so tonganba high. Then allied health professionals like laboratory technicians, lab technicians, pharmacists, other health professionals like paramedics, support staff, the sanitation staff, housekeeping, including ward attendants, security guards, food trolley bearer, then human resources ki capacity building, conduct and behavioral standards, safety measures for HRH. Simyamze mai makhada loina ꯑꯩꯈꯣꯏꯒꯤ details ꯂꯣꯏꯅ ꯂꯥꯛꯈꯤꯗꯣꯏꯅꯤꯀꯣ so human resources for health there are 8 checkpoints 8 checkpoints se ahambada administrative staff doctors nurse paramedic support staff leireko then IPHS norms ki matung inna medical officer amana nongmada 75 patient phauba up to 75 patient phauba yengbagi hai general medicine na 60 patients yengba IPD gi 20 patients per day yengba aduga 20 procedures per week tauba hai general surgery obstetrics and gynecologists pediatrician orthopedics and so on aduna kaigumba khoina HR watli hairu matamda as per IPHS adugi mido hairiba IPHS norms ki makhada taugadoba duty do taubra hairpa matamdadi ꯑꯩꯈꯣꯏꯒꯤꯗꯤ geographical ꯀꯩꯅꯣꯁꯨ ꯄ꯭ꯔꯣꯕ꯭ꯂꯦꯝꯕꯨꯗꯤ ꯂꯩꯕꯅꯤꯅ ꯁꯤꯃꯛꯇꯤ possibility oide, but this is as per IPHS that a medical officer is supposed to see 75 patients per day and specialists are supposed to see at least 60 patients in a day. adum yengbasu adum yawramgani ko yawro habna but then it's just what the IPHS guideline says. Anesthesiologist, ophthalmologist, dentists, 20 patients per day because the procedure ngakta yamba tawbonina ENT, psychiatry, radiologists, moina tawgadaba mayam staff nurse kaya laigadawno habado as per norms INC gi norms ta kaya laigadawno p aduga p su p ko ay adu utjarake hore 100 tests per day lab technician amana tawgadawse semi auto analyzer oitaragadi and 200 tests per day if auto analyzer season ataragadi admai tawdana moi gi role moina tawgadawba duty mayam se IPHS na breakup ama loinama define tawbiye ko counselor na 20-25 counseling per sessions per day loba kind of mana all it is all cannot tawbi hatare. Then medicines. Medicines is very interesting for the level of district hospital. I will not be reading one by one, but there are many, about 200 and see about the sub-district hospital, 375 medicines are supposed to be available at district hospitals. 311 medicines and consumables are supposed to be available at the level of SDH. aduduna 375 essential drug list to available oigadawbani haina hai adaida akoina asaigi kenose taw matamda ODK tool da assessment tawbu matamda drugs to laitabanina adugi mark to sum chathara ko then diagnostics ki part da there are lots of diagnostics ki parts da ai cannot nangdre one by one nangdre but there are lots of like 211 minor 200 and something oiko magi diagnostic tests as per IPHS district hospital da tawgadoise then equipments mayamam lay equipment say it's the list is very long so I will not be uploading here but just let's akoina tamna kai akoiki only the kano oiba points only the kitang major oiba points du kitang sum yeng seba accessibility for any district hospital good road connectivity laiba ama dakar lay public transport ki access mamangda district hospital ki mamangda akoigi bus stop kumba kaigumba ama laita adumba ama thambiba natragana haidi akoina bus stop ki public transport ki mamangda da bus stand ama hapo haiko location safety flood thokta jaga gumba low lying areas kumba sigisina anoba sabagi matamdani ko utilities we have to be careful about water electricity telephone sewage disposals adagi environmental the pollution thokta ensure the seismic safety when planning the matamda then space utilization most of the times housing the vertical construction tau nanaba high ko vertical construction tau nanaba high floor planning to matamda LDR ki complex oina hapa hai LDR complex ka labor room complex ka khene LDR complex hai taragadi mama gi tumbam duda dum angang pokpagi phibam dani ko haidi yamna yumda dum pokpagi type to the oi doine magi maternity ward to the labor gi setup se lai doine and OPD should be on the ground floor LDR should be on the ground floor wherever possible at least 10 meters of space around the boundary wall should remain open. Adequate width for fire engine access should be provisioned, measuring no less than 6 meters. General appearance and facility upkeep. Nasa haikiba clear signage Adequate signage on main and connecting roads is easily visible. Lamni yang padadum asigi district hospitals e laire khangnanaba. Building maintenance uniform color scheme oiba. Free from any seepage, cracks, broken windows oiba. Safety features like anti-skid flooring, adequate lighting, clear access for vehicles. Koigi can say anywhere the kwena flooring se taw matam da skid free anti-skid oiba tile gumba admaina sijinabiba haibani ko. And always district hospitals should be defined as a silenced zone. Wayfinding accessibilities sigisina directional signage mayams. Directional signage say how the name of the facility displayed, name of the departments are displayed. Each department is clearly marked. English, Hindi, and local language. Color coding for larger facilities. Green gumba ka oibanika. Hospital layout is displayed near the entrance. Hospital ki layout se sub center ki level bokta adum important oiko when assessor lak matamda magi facility ki layout se mapanda somda chatlagan adu laiduni right ta chatlagan adu laiduni de for district hospital ki so for PHC CHC loimba ki yam chauna facility ki layout se keno taw gadaune happy gadaune habani ko. Then tactile pathways for visually impaired. Tactile pathways ai ta agadi makha da yellow ki line tawba blind chatpada adi yam line khangmaduni ko adugi line chatpadu sum yengbiyoba. Vertical sum chalam the horizontal amma hek leram taragadi it indicates left tara right tara some atopa thek pa masoi laire haine boko natraga dot to leramagadi left tara right tara there is something. Disabled friendly access infrastructure must follow guidelines and space standards for barrier free build environment for disabled elderly person. See is akwai NQAS ta akwai na haiba disabled friendly gi ramp kumba railing kumba disabled friendly toilet mana masana khutna pairaga toilet tawba gadawba adugumba sing do dum yauzai ko. Parking and landscaping, parking facilities, separate parking for staff, separate parking for visitors, especially near the ambulance the vehicle chang ambulance na tongana khamaga thamba aduga vehicle chang payaba ambulance tum chang payaba parking laina mayai to the lambi shemo having ko. Gardens and green spaces, gardens and open spaces provide a positive healing environment. Herbal garden thambagi di high NQAS study not very much into herbal garden. Ayamba gardens landscaping high not much herbal garden ki matang the high deco. It is about the herbal garden yawe, but in case of NQAS there is no herbal garden. Environmental friendly features like solar energy, which Hausiki Matamdadi Selco I think many of the facilities have been given uninterrupted power supply through Selco. Aduduna Selco laita solar energy renewable energy rainwater harvesting taugadoni high IPHS ki norms ki makada kaigumba any yum natraga kanum laiba matamda jingana makada khajalakanda rainwater harvesting taubagi mark lay. LED lighting can say bulb than can high LED bulb oina thalo high and green roofing high solar reflective materials. See say green roofing is who kai gumba solar plate pan otherwise reflective material solar gi can do hapa manatagana vegetations thamba gumba high when circulation area design standards corridors should be at least 3 meters wide. I say 3 meters wide it is about trolley anise yam line a trolley anise thaina bachanba. All two-way swing doors should have vision panels giving visibility to 800 to 1500 meters height. Clear headroom of at least 200 above the tactile guiding blocks is required. Chidi akoina hozik yam kanna tawba when design tar matamda high bedugini RAM key specification and mapi sige high 1:15 to 1:18 high set. Put a wang matamda put traunga se put a wang matamda put traunga se akoina slope tham gadong haveniko. Yam yami chumme, but then it is necessary because akoina we expect anybody who is on a wheelchair to come up to the facility on its own. Hadi mana kai gumba mi yaw draga suma kakhalakpang ngam mana 1:15 to 1:18 na PSA. Fire safety norms must be followed, pass, race, aduma mayam do loina ma koina keno tawgadawni. Then disaster and emergency preparedness, structural safety, fire safety, training and drills, mock drills ka laibagi general ngasagi upkeep to the loin yawbani ko sige se electrical and power, electrical power and fire safety, fire detector moina kanona oina pirakani akoigi fire department duna district hospital ki especially kadai kadai da karamba type ki fire extinguisher pangadabono habado hairakani. Electrical power supply have to be adequate. Water supply say 450 to 500 liters per bed laigadawni for any for one bed. Aduga 3 days of storage laigadawba. Aduga water ki source se independently ani laigadawba. Round the clock piped water supply, overhead storage tank su laigadawba. Overhead tank to overhead tank ki storage su mathakta laigadawba. Aduga makhada underground storage tank su laigadawba. Aduna underground day mathakta chinkhalakanda sum per day ki 450 to 500 liters ki hisabda mathakta makhada ani sida store tawraga thamba haibani ko. So waste management systems is about biomedical waste management ki akoina hojikta hai giba segregation, storage, treatment and disposal duni sidadi yamna hena discuss tawroisi. It is about waste management system. Waste management say IPHS ki dadi, it is not only about biomedical waste management system. It is concerned with the general waste also. General waste to the blue green blue is for recyclable wastes like plastic, and green is for biodegradable wastes, which goes to the compost pit of that particular facility. Outpatient service ki infrastructure the aina sa haiba the minor registration area ma, waiting area ma, consultation area ma mana 15 to 20 meters per square per counter pi gada only haiko. Sigisana IPHS norms ki matungina phanggadawbani haibani anoba sakanda disi myamja loina implement tawrani. But if hanagisida laita taragadi no issues laitragadi laitre kaidi upai lay, but NQAS tadi shumaina chawdaba yadi haibadi laite. If the population under the encatchment area aduna kaigumba aduda phajana service piba ngamtaragadi, that is enough. Waiting area say 400 square feet or 25 chairs haibani ko moise kaigumba waiting area the chair kumanga thava chantaragadi, that is well good enough. Consultation room minimum 12 square meters with examination table, X-ray view box, curtain screens and hand washing facilities. Patient amenities, the fan, clean drinking water, gender sensitive toilets. Desirable amenities include air condition, desirable because essential nothing. Air condition, TV, LCD, sugumba mayam se patient ki amenities thambiyo hai. Clean drinking water ga fan ga city always everywhere the important or mandatory ko. Emergency care infrastructure, triage area ma, clinical zones ma, support services ki area ma. Triage area should be before the OPD or before the registration counter. Clinical zones like 4 zones which we do in Canada. OTIDA like red, yellow, green and black, which we call protective zone, clean zone, sterile zone and disposal zone. Support services, close linkage with emergency OT, lab, radiology and clinical care areas. Critical areas, there are 2 kinds of critical areas as per IPHS, HDU ga, ICU ga. HDU da my space say 20 to 24 meters square per bed, ratio is 1:2. Aduga ICU da ratio is 1:1, 25 to 30 meters square per bed. Room should be sound treated, air conditioner. As I've said earlier, they are planning to make new facilities as per IPHS, but then akoina hanale facilities in the sigi mayam say most of them IPHS compliant oidaba yam yawe, so adudadi yam kahena kanu to bangam deko. But IPH su 100% phango habanate, 80% phangadi well good enough. Operation theater complex, zoning, humidity, temperature, air exchange. Operation theater as per IPHS guidelines, the zoning tawgadaba 4 zones, that is protective zone, clean zone, sterile zone and disposal zone. Temperature 21 to 24 degrees Celsius at all times. Humidity 50 to 60%. Air exchange se koi na machine amna taro tawgadawni ko air exchange se. We cannot just manually make air exchange. Air exchange should be done. 20 air exchange. See se set the way I machine do the ko. Laminar flow, self-closing device, viewing mirror, viewing window, OT complex should have reception, pre-operative room, post-operating room, reception in the protective zone, pre-operative and post-operative in the clean zone. Labor room complex, the space requirements about 20 to 25 to 350 square feet per LDR unit. Per LDR unit, including space for alternate berthing positions, natural light dimmable light attached facilities. In case of labor room complex, the AC taragadi, the newborn care corner should not be in the room itself. My tongan bazaga because AC pan by yadi newborn care corner dadi. So whenever we design a labor room, we have to have a separate small area as newborn care corner so that newborn do AC food because newborn the heat the car lay dimmable lighting. Attached facilities like attached toilet is very, very important. Without Lakshya, though labor room ki manung the toilet like Andragadi, it will be hard to certify. Special newborn care unit. Special newborn care units, special care for sick newborns. Sida SNCU ki manaka kangaroo mother care ki area, adagi breastfeeding corner, kaika suma loina laigadawni SNCU preferably nearby to the labor room nearby to the labor room they put so SNCU facilities triage reception area se akhoi kano da natana akhoi da pokpa da natana mapandai purak pasu khona admit tawba yai aduna triage and reception area should be there, waiting area with amenities. See ki se huzik all new concepts are coming up. SNCU ki SNCU ki baby the P do river sings ears housing meter mama sing so in a train taura kan the mama sing do the oina train cannot on bagi mama sing do in a care to han bagi hidak pi bagi khot bagi everything say mama do phasana train tawga SNCU manungda mother newborn care unit MNCU mother newborn care unit se shigi concept se is the oina ayam sum chathare ko and it will be implemented eventually. Mother newborn care units aduga akoida staff ki shortage lairasu issue laitaba mothers in phazana train tawrakanda mother will be more and more dedicated to akoi moi angang sing do kano tawbagi haita. That was the topic in the World Patient Safety Day for this year, newborn care and do the. Then human resources for health, as we all know, doctors, nursing staffs, allied health, administrative staffs, and support staffs. Nursing staffs, as per INC norms, 1:6 for general ward, 1:1 for ICU, 1:2 for HDU. Quality assurance and clinical governance, as we know, quality team form toba, internal assessment toba, KPI maintain toba, standards में do कोई policy के में do implement toba, then NQAS की certification toba सीधी कोई ना ngasai degi tawra iba poto do masagi sida yauzarak pasni ko. And then clinical governance is about noigi all certifications like biomedical waste certification, policies, fire certification, citizen charter, IC materials, all those things comes under clinical governance of IPHS. Thank you very much. Am I audible? Mayam Tabibra.
Tare.
Waraba male mayam.
Hoi ware.
Ayun pong taradagi.
Okay, Loshana, a few comments, please. Tamo Dr. Steve Yaubiribra, and from other hilly districts also, if there is any questions, you can put it up on the messages, or you can using feedback at the same time WhatsApp group. Thank you.
Thank you, Susil.
Thank you.
Thank you.
Thank you.